Hello everyone. I guess I'm live. If I'm clearly visible, audible to you guys, can you give me a thumbs up in the chat box so I can start the session ahead? Any one of you? Osama, Dr. Shubh, Irfan, anyone? Can you give me a thumbs up? A very good morning to all of you. Yes, okay. Thanks for confirming. Thank you so much. So I welcome you all for today's session. A very good morning to all of you. I am Dr. Priyanka Sachdev here, and today I'm here to take a pathology session for the FMGE aspirants. It's a remarkable rapid revision. So today in 6 to 8 hours, we are going to cover entire pathology, the high yielding topics of pathology, the hot topics from which there is high probability of coming question in your exam. So all the topics which are repeatedly asked in previous year question papers of last 5 years, I'm going to cover those topics. In your exam, the FMG exam, the topics are repeated. Exact questions are not repeated. So I will be concentrating on the topics which are repeatedly asked in your exam, and we will be prepared for the entire topic, not just for that particular question. So first I will teach you a particular topic, and then I will launch the questions which are already asked on that topic. So in this manner, we are going to cover entire pathology today. I will be covering the entire pathology in 2 sessions. This is session number 1, in which I am going to cover the general pathology and hematology first. And in session 2, in the evening, we are going to cover the complete systemic pathology, right? And if you people have any doubt, you can ask me here in the chat box. So I will address it. Definitely, I will address it, right? So without wasting any further time, let me go ahead. So let me start. As I have told you, give me a minute. Just a second. Okay, so as I have told you, in the pathology, there are 3 portions: general pathology, hematology, and systemic pathology. Let me start with general pathology right now. So I'm starting with general pathology. Yes, are you guys there? Can I go ahead? So in general pathology, let me start with, there are 5 important chapters here. Let me start with chapter number 1. The first chapter, cell adaptation, cell injury, cell death, apoptosis, necrosis. So let me start with the first topic, very first topic, cell adaptation. Right. So what all important questions come from this topic in your exam? What is the probability? So we will be covering all topics. So, human body is made up of cells. From head to toe, we are made up of cells. Cell is the structural and functional unit of life. We all know that. So all the cells in human body are in homeostasis. What do you mean by homeostasis? All the cells in human body, they perform their particular function. They have a particular structure. So normally the cell is in homeostasis. You can see it is a cell. It is in homeostasis. But whenever any stress acts on the cell, the stress can be physiological. It can be pathological, right? So whenever any stress acting on the cell, 3 things happen one by one in a sequential manner. The first thing happens is cell adaptation. Right. If the stress continues, the second thing happen is cell injury, that is reversible cell injury. First, reversible cell injury occurs. And if stress still continues, the last thing is irreversible cell injury. As the name indicates, it is irreversible. What do you mean by irreversible? Irreversible cell injury is equal to cell death. It is equal to cell death, which is of 2 types, apoptosis and necrosis. Right. So we have to cover 3 important topics right now. The first topic is cell adaptation, which is reversible. Once you remove the stress, the adaptation will be reversible automatically. The second is reversible cell injury. Still it is reversible. If you remove the stress, again it is reversible. But the last one is irreversible cell injury. Once the cell is dead, you cannot make it alive again. Right? Once the cell is dead, you cannot. Now there are 2 types of cell death, apoptosis and necrosis. Now, what do you mean by 2 types of cell death? If I can say, one is suicide, one is murder. Both are death. So actually, apoptosis is equivalent to suicide and necrosis is equivalent to murder. So what does it mean? I will explain you everything in detail and what important questions will be coming from your exam. Okay. So the first thing is the cell adaptation. You can understand like this. How many hours you study in a day? Daily. How many hours? I'm asking you. So you may say, ma'am, 6 hours, 8 hours, 9 hours. So this is your daily routine. So that is your homeostasis. So you are studying for 6 to 8 hours daily, right? But what about a day before exam? How many hours you study a day before exam or few days before exam? So you will say, ma'am, 12 hours, 14 hours, maybe 16 hours. So the exam is acting as a stress. And to overcome that stress, your body is doing adaptation and you are studying more. So this is your adaptation, right? Your body is adapting to overcome the stress, right? But if exam lasts for 1 month, 2 months, you can do this routine. Daily you can study for 10 to 14 hours. But if exam lasts forever, imagine what will happen. So you may have various diseases due to decreased sleep and all. That is irreversible cell injury or death. So you can understand the sequel like that with an example, right? So let me take the first thing, cell adaptations. As I have told you, cell adaptations are reversible, right? And these are the structural changes in response to stress, to overcome the stress. To overcome the stress, that is the definition, right? Now, there are 5 types of cell adaptation. Let me explain you the 5 type. You already know: hypertrophy, hyperplasia, right? What do you mean by the term trophy and what do you mean by the term plasia? The term hyper means more. Hyper ka matlab hai more, but trophy means size. So here the cell increase in size, and hyperplasia, plasia ka matlab means is number. So here the cell is increasing in number. So increase in size, increase in number. Atrophy, again trophy means size, right? So A means decrease. It's decrease in size and number. Metaplasia means transformation of one type of cell to another. So either it's squamous to columnar or vice versa, from columnar to squamous, right? And last one is dysplasia. It's disordered cellular development. So we will be discussing the important topics from all these 5 type of adaptation, which are important from exam point of view, right? You can see here I have drawn a normal cell. Can you see the size and number? I have drawn only one cell. The number is 1 and you can see the size, right? So the 5 type of adaptations are shown beautifully in this diagram. Here you can see the size of the cell is increased, right? But the number is still 1. So it is hypertrophy, right? Here you can see the number is increased, not the size. The size is same as that of normal cell. You can see the size is same, but number instead of 1, it's 3. So I can see it's hyperplasia, right? The third one, you can see that size is decreased. Compare the size of this with the normal cell. So this one is atrophy, right? This one is metaplasia. You can see metaplasia. So one type of cell converted to another. So initially it was squamous, now it's columnar, or initially it was columnar, now it's squamous, whatever, right? And the last one is the dysplasia. It is disordered development. It is a pre-malignant lesion. Everyone give me a thumbs up in the chat box if you got the definition of the 5 type of adaptations, right? Now, what is important in your exam? In your exam, the examples of the 5 type of adaptations is important, from which various types of MCQs come. So, in your exam, you will get one of the example, like pregnant uterus. Pregnant uterus is an example of what, right? In aging, the brain decreases in size. It is an example of what? Endometrial hyperplasia is an example of what? So you should be understanding the examples of each type, right? Everyone give me a thumbs up. Come on. You have to be interactive to make this session more interesting. Can we go ahead? Can we? So I request you to make this table with me, right? So let me start with hyperplasia. The first one is the hyperplasia. I already told you it's increase in number, not the size. Number increase है, hyperplasia, not the size. You can see the diagram, a beautiful diagram. Here we have drawn one cell and here multiple cells are there. But the size is same. If you see the size, it's approx same. So only number is increasing. It's hyperplasia because of the stress. Now hyperplasia is of 2 types. It's physiological and it's pathological. I will give you 3 examples of physiological and I will give you 3 examples of pathological, right? So what are the 3 examples of physiological? The female breast. Can you see female breast? Now let me draw female breast here. The size of the female breast increases in 3 situations. What are the 3 situations? At the time of puberty, at the time of the puberty, at the time of the pregnancy, and at the time of lactation. These are the 3 conditions in the life of a female where the size of the breast increases. So size of the breast will be like this. It will increase in size. Instead of this, it is increasing. Now, why the size of the breast is increasing? So there are cells inside the breast. Actually, these cells increase in number. They increase, they divide, and they increase in number. So because of increase in number, the size of the breast is increasing. So what is the stress here? What is the stress? The stress here is the hormones, estrogen and progesterone hormones. So in this condition, these 3 conditions, there are hormones present in female blood. And that hormones is acting as a stress. And that is causing increase in size. So the first example, it is the female breast during puberty, pregnancy and lactation. You got my point? That is the first example and it is physiological. It is not a disease. The second example of the physiological is pregnant uterus. Can you see here? This is a normal uterus of a female. Can you see the size? And this is the pregnant uterus. During pregnancy, the uterus increases in size to accommodate the fetus inside that. Of course, we know that. But why the size of the pregnant uterus increasing? Why? Because now it is an example of hypertrophy as well as hyperplasia. The only example in which hypertrophy and hyperplasia takes place simultaneously is a pregnant uterus. You got my point? Now, this is the gross picture. Please see the microscopy. Now, I am preparing you for image-based questions also in your exam. Now, see the microscopy. Can you see the cells here? Here the cells are small. This is normal uterus. And this is pregnant uterus. Now, see the size of the cell here. Can you see size of each cell? So, here size is also increasing. And if you count the number, here number is also increasing. So pregnant uterus is an example of hypertrophy as well as hyperplasia. We can see the size is also increasing and the number is also increasing. You got my point? So size as well as number both are increasing. It is an example of both. And the third example is compensatory hyperplasia, very important MCQ. What is compensatory hyperplasia? Imagine one of the person have given one of the part of the liver to another person has donated a part of liver, that is hepatectomy is done, right? Or one of the kidney is donated, one of the kidney, right? So the another kidney, humans have two kidney now, so another kidney will increase in size to compensate the loss of one kidney, or the remaining liver will increase in size to compensate the part of the liver which is lost. So this is known as compensatory hyperplasia. You got my point? So that is compensatory. So these were the three examples of physiological, right? Coming on three examples of pathological hyperplasia. Now these are three diseases I am going to tell you. The first is the endometrial hyperplasia. The first is the endometrial hyperplasia. Can you see here? There is endometrium. The uterus of the female have endometrium, and if there is estrogen axis due to any reason, external estrogen or any estrogen secreting tumor in human body, that will cause hyperplasia in the endometrium that results in a disease known as endometrial hyperplasia. Such females bleed more during the menstruation, right? So that is a disease. It is not physiological. The second is benign prostate hyperplasia, BPH, in males. So prostate is a gland in males. Can you see here? The prostate is a gland. It is present only in males, not in females. It is present around the urethra, right? Now, it can increase in size due to more testosterone. Here the hormone is the testosterone. It is increasing in size and compressing the urethra. So this patient will have problem in passing the urine, in micturition. So there is the most important complaint here will be dribbling of urine. The patient cannot pass the urine smoothly. Give me a thumbs up. You got it? Can we go ahead? Give me a thumbs up, everyone. Give me a thumbs up. And the third example here is the skin warts. Skin warts. You know, on the human skins, we have keratinocyte. So this is one of the cell of the keratinocyte. Here, the stress is the HPV virus. If HPV virus is entering in the human skin, it can cause hyperplasia and produce a lesion known as warts. So let me summarize. So what is hyperplasia? We have finished hyperplasia. Hyperplasia is increase in number, not the size. It's of two types, physiological, pathological. Physiological and pathological. We have seen three examples of physiological and three of pathological. The examples are important for your MCQs. So what are the three examples of physiological? It's female breast at the time of puberty, pregnancy and lactation. It's pregnant uterus at the time of the pregnancy. And it's compensatory hyperplasia. Compensatory means one of the kidney is lost or a part of liver is lost. So these are the three examples of physiological. In pathological, three diseases you have to tell me. So first disease is endometrial hyperplasia, I told you. Then I told you warts. And what is the third disease I told you? One more disease I told you, no? So in this BPH in males. So these are the three diseases in which due to increase in number of the cells, the person have diseases. So you have to learn the examples. That's all about hyperplasia. Coming on hypertrophy. Hypertrophy is increase in size, not the number. Increase in size. It's also of two types. Let me tell you. It's increase in size, not the number. It's just opposite. Increase in size of the cell, not the number of the cell. So you can see this cell, it is one cell. Here also, it's one cell. But see the size. Number is not increasing, but the size is increasing in response to stress. You got my point? Again, it's of two types, physiological, pathological. I want to give two examples here, two examples here. Right. So now I'm going to give you examples of hypertrophy, not hyperplasia. Physiological, one you already know. I have told you. Pregnant uterus. It is a common example between both. Right. So the first example is pregnant uterus. You can see the pregnant uterus. It is an example of both. I have explained you the hypertrophy as well as hyperplasia. It's the most commonly asked MCQ in your exam. Can we go ahead? The second is the hypertrophy of the skeletal muscle. Can you see the skeletal muscles here? Please appreciate the skeletal muscles here. So if someone is doing the laborious work or gymming, so the biceps, tricep increase in size. It's due to hypertrophy, not hyperplasia. So that is the two examples. Coming on pathological hypertrophy. So pathological hypertrophy, the first example is the cardiac muscle. Imagine a situation, can you see this is the mitral wall here in the left ventricle. Imagine a situation if the mitral wall stenosis occurs, what will happen? If the left, so normally when the left ventricle systole, the blood goes here into the aorta. But if mitral wall stenosis I'm sorry, not mitral, it's aortic wall. Aortic wall stenosis happens. So blood will not go in the aorta, blood will accumulate in the left ventricle only. It is causing a stress. It is causing. So because of which the wall of the left ventricle will become thickened and thickened to do a vigorous systole. It is known as the disease is left ventricular hypertrophy, LVH. LVH is the disease because of the aortic stenosis, right? And the second disease here you can see is the cardiac achalasia. What do you mean by cardiac achalasia? You can see this is esophagus, this is stomach. At the junction, there is a sphincter and it is open. When we swallow anything and chew and swallow anything, so the sphincter open, it allows the passage of the food from the esophagus to stomach. But in certain condition, there is hypertrophy of the sphincter. You can see the sphincter is closed. So food will accumulate here. Food cannot pass from the esophagus to stomach. And this disease is known as cardiac achalasia. Right. So it is an example here. Right. Yes, HOCM also you can take the example here. So hypertrophy, hyperplasia, we have completed. Coming on the third, that is atrophy. What do you mean by atrophy? What do you mean by atrophy? Atrophy is decrease in size and number of the cell, not increase. Can you see a cell here? Can you see a cell here? Compare the size. Compare the size. So size is reduced. That is atrophy. Again, it's of two types, physiological and pathological. You have to learn the examples. Can someone of you give me the examples of physiological atrophy? Anyone? Nitish, Osama, Divya, Irfan, anyone among the audience? Anyone can answer. Do you know any example of physiological atrophy? Do you know? Yes, yes, Osama, very good. So thymus you can say, or lymphoid organs. So you know, in childhood or in fetal stage we have thymus, but it regresses when we grow. So thymus undergo atrophy with increased age. Ovaries in female after menopause. So after menopause, the ovaries shrink, the gonads shrink. Yes, very good, Gulnaz, very good. The brain, you know, the best example, it is a IBQ. It is a IBQ in your exam. Can you see this is a brain? You can see the gyra and sulci in the brain. So brain undergo atrophy with aging. So this is the brain of a young person and this is the brain of an old person. Now see, you can see the atrophy of the brain, right? And the last one is the uterus after delivery, after parturition. So in uterus, what we have learned? See the summary of the uterus. This is the normal size of the uterus. During pregnancy, it increases in size. We can see it increase in size because of hypertrophy as well as hyperplasia. So in pregnancy, both come. Hypertrophy and hyperplasia result in increase in size of the uterus during pregnancy. But after delivery, during parturition, again uterus shrink in size and become normal size. So this is atrophy. So uterus is coming in three different examples: hypertrophy, hyperplasia, and atrophy. Give me a thumbs up. Everyone give me a thumbs up. Can we go ahead? Can we go ahead? Yes. Embryogenesis, Mammon, you can say, I understand you are asking for this, like how our digits are formed during embryogenesis, right? So you want to say that the cells between two digits undergo atrophy at the time of the embryogenesis, and that's why the embryo. So in embryogenesis, better than, yeah, you can say atrophy, but better than atrophy, go with apoptosis. So these are the cells which undergo apoptosis there, right? Yes, these are the apoptotic digits. So better answer will be apoptosis there. So can I move ahead? So these were the examples of physiological. Now let me give you the examples of pathological atrophy. Pathological. So pathological atrophy is of 6 types. If someone don't eat anything, imagine this is a person, the person have cancer or some severe illness, the person is not eating anything, right? So all the organs, the complete body undergo atrophy. All organs from head to toe, it's atrophied. And this condition is known as cachexia. This condition is known as cachexia. You know, so this is the definition of cachexia. That is known as starvation atrophy because the person is not eating anything. That's why atrophy is known as starvation atrophy, right? The second type of atrophy, you can see the 2 kidneys here, kidney and kidney. This kidney is getting proper blood. The renal artery is normal. But imagine this kidney, the renal artery the renal artery is obstructed. So this kidney is not getting proper blood. So this kidney shrink in size. It undergo atrophy and it is known as ischemic atrophy because it is due to ischemia. This one was due to starvation. This one is due to ischemia. You got my point, right? Can you see this is a polio person? See the legs of a polio person. Can you see the legs, the hands of a polio person? They are atrophied as compared to a normal human. Why? Because the nerves supplying in polio, what happens in polio? In polio, the virus damaged the nerves supplying to the skeletal muscle. So the nerves are damaged. That's why the organ undergo atrophy. So that's why this atrophy is known as neuropathic atrophy. The best example is polio. The best example is polio, right? The third one. And the fourth one, imagine if someone is having fracture in the tibia, fibula, humerus, anywhere. So the person will have a cast, cast or plaster for 1 month, 2 months. The orthopedician will put the cast. So person will not use that limb for 1-2 months. And after opening the cast, that limb is atrophied as compared to another limb. You got my point? Because of disuse. This was not used properly. That's why it is known as disuse atrophy. Right? So give me a thumbs up if you got. Now imagine you have a better pictographic memory is more as compared to if I give you the theory now you will forget. But if I show you the images now you will not forget. So tell me the 4 types of atrophy. Can you tell me what it is? Starvation atrophy is cachexia, right? Ischemic atrophy in renal artery stenosis. Disuse atrophy in fracture and cast. And neuropathic atrophy, the example is polio. Give me a thumbs up. There are 2 more. Humans have hypothalamus, pituitary and organ axis. From the hypothalamus, hormones are released. They act on pituitary. And from pituitary, 4 hormones are released. ACTH go to adrenal gland, TSH go to thyroid, and LH and FSH goes to ovaries and testes in male and female respectively. You know that, I guess. Imagine a person whose pituitary is damaged. There is no pituitary, either congenital or due to trauma, due to tumor. Pituitary is not there. The condition is known as hypopituitarism. Hypopituitarism. What will happen in that condition? What will happen? These 4 organs will shrink in size. Which 4 organs? The adrenal gland, thyroid, ovaries and testes. They will shrink in size because they are not getting the hormone. This atrophy is known as endocrine atrophy. The atrophy is due to hormonal deficiency. That's why known as endocrine atrophy. Give me a thumbs up. Give me a thumbs up. Yes. So that is hormonal atrophy. And the last one is the pressure atrophy. The last one is the pressure atrophy. Imagine someone is having meningioma in the meninges. Can you see here? There is a meningioma. Let me draw. This is a meningioma here. Okay. So this meningioma is compressing the skull bone. It is compressing the skull bone. So due to the pressure, the skull bone is atrophied. So it can happen anywhere. This is the example of pressure atrophy, right? So yes, this one is meningioma. It's not pituitary adenoma. But the distal portion of the swelling is seen in the plaster in that hypertrophy. No, Sumit. It may be edema, the distal swelling you are talking about. Don't call it hypertrophy. It can be edema, but not hypertrophy. You got it? Give me a thumbs up. Still, if you have doubt, please write down. So we are done with hypertrophy, hyperplasia, atrophy. Specifically, you know the multiple examples. Now, don't try to mug the examples as a list. You will be given 4 options. You have to just identify the correct answer. So once you understand the examples, in the example, you can take the correct answer. The next one is the metaplasia. The 4th one is the metaplasia. What is metaplasia? Metaplasia is transformation of one type of cell to another type of cell. So it can be initially the cell was squamous. Due to stress, it converted to columnar. Or initially the cell was columnar. Due to stress, it get converted to squamous. So that is the 2 type of metaplasia. Now we have to see finally what is formed. Here finally columnar is formed. So this is known as columnar metaplasia. Right. So in columnar metaplasia, squamous convert to columnar. And here finally squamous is formed. So this one is known as squamous metaplasia. So here columnar converted to squamous. Don't get confused. If I say there are 2 types of metaplasia, squamous and columnar, you should be able to tell the definition. Don't do it reverse. So what is found finally, that is the name given. Are you getting? जो finally बन रहा है वो नाम है metaplasia का. Finally squamous is formed ना, so it is squamous metaplasia. And finally columnar is formed, so it is known as columnar metaplasia. Yes, I am coming on the examples, Osama. Give me a minute. So have you got it? First understand what is formed finally. The 2 types. Now I will give you 4 examples here and 2 here. Right? You have to learn the examples of metaplasia. Very important. Let me come on squamous metaplasia. This one. So here, initially the organ is columnar and after stress, it get converted to squamous. So tell me 4 organs in which initially columnar epithelium is there and due to stress, they convert it to squamous. Tell me 4 examples, 4 such examples. So don't look at the theory, look at the diagrams. Now I have given my much time before this lecture to draw these diagrams for you. These are not given in any book. I have made this diagram by myself to make your concepts clear. You got my point? I can see 4 organs here. The first organ I can see, these are the lungs or respiratory tract. You know the lining of the respiratory tract is the pseudo-stratified ciliated columnar epithelia. So initially it's columnar epithelia. You are getting the red one is the columnar. Can you see this one is columnar epithelia? Right. The second organ I can see here is the gallbladder. It's also columnar epithelia. The third organ I can see is the prostate. It's also columnar epithelia. And the fourth organ I can see is the endocervix. The cervix have 2 type of epithelia. Endocervix is columnar and ectocervix is squamous. So I'm talking about endocervix. Endocervix. It's also columnar. Right. Initially they all were columnar in me, you, everyone. These 4 organs have columnar epithelia. Now let me tell you the stress. If someone smoke, I don't smoke, but if someone smoke, so smoke acts as a stress. So because of the smoke, the columnar convert into squamous. You got my point in the lungs. So it is an example of metaplasia, squamous metaplasia. Columnar get converted to squamous. In the gallbladder, if someone have a calculus means stone, right? So stone act as a stress, because of which columnar convert into squamous. Give me a thumbs up. You got my point? In the prostate, due to inflammation, the inflammation acts as a stress. Because of the inflammation, the columnar get converted to squamous, right? And in the endocervix, the stress will be the prolapse of the uterus, right? The uterus are held by the ligament now. If the ligaments are cut or teared, there is prolapse. The prolapse is causing a stress here, because of which the columnar get converted to squamous. Give me a thumbs up. So the 4 organs with the 4 stress, in all of them, the common thing is that initially they all have columnar. And finally, the columnar get converted to squamous. But the stressor is different in them. What is the stressor in each of them? You should be able to understand that. So in lungs, it's smoking. In gallbladder, it's the stone. In the prostates, it's infection and inflammation. And in uterus, not in uterus, in cervix, the endocervix, it's the prolapse of the cervix. Everyone give me a thumbs up. Jitne audience, utni thumbs up. Fatafat. We don't have time. We have to be fast. Right? Fatafat, give me a thumbs up. Come on, you got it? The 4 examples of the squamous. The common thing in all 4 is that initially they all have columnar epithelia. And after stress, they got converted into squamous. But you should know the stress in each of them. Right? So this is the first type of metaplasia we have done. The second type of metaplasia is the columnar metaplasia. In columnar metaplasia, initially the organ has squamous. It is reverse, huh? And due to stress, it is getting converted to columnar. So tell me 2 such organs. 2 such organs in which initially the lining is squamous. Normal lining is squamous in you, me, everyone. But due to stress, it get converted to columnar. Can you tell me? Yes. Very good. Muppenny, Divya, Isak, very good. So 2 organs. Everyone is saying about the esophagus, right? Okay. So this is the first organ. You know, esophagus, everyone is right. See, this is normal esophagus, this one. Normal. In me, you, everyone, it's like this. Can you see? The esophagus have a blue color lining. This one is squamous. Right? And the stomach have red lining. This one is columnar. So in me, you, everyone, it's like this. The esophagus have squamous and the stomach have columnar. And this is the junction of esophagus and stomach. But have you ever thought why God has given the 2 different lining in 2 adjacent organ? Why? Kyun God ne alag-alag lining diya? Both organs are continuous na. If God wishes, it can be a continuous lining. But there can be some reason now why it is, everything has a reason, right? Why it is having a squamous lining and this one is having columnar? Why? Both the organs are continuous. Because there is acid in the stomach. HCl, acid. Esophagus don't have acid. And columnar epithelia can bear the stress of acid. Squamous cannot bear. Squamous cannot bear. This is the reason. You got my point? But in some person, there is reflux of the acid. That acts as a stress. The disease is known as GERD. That is gastroesophageal reflux. Reflux disease in which acid goes upwards in the esophagus. So what will happen? That will give stress to the lower esophagus. Lower esophagus, it will reflux only in lower, not in upper esophagus. So here in lower esophagus, the lining will change because of the stress. Initially, it was squamous and now it converted to columnar, and this portion of the esophagus is known as Barrett esophagus. So what is not buried esophagus is important in pathology. It very much MCQs are asked every year on buried esophagus. So it is an example of metaplasia. It is an example of columnar metaplasia. And initially it was squamous. Due to the stress, it converted to columnar. The stress is the GERD. Everyone give me a thumbs up. You got it? You got it? Can we go ahead? Can we go ahead? Yes, goblet cells will be there in the columnar epithelia which is formed here. It will contain the goblet cells. Yes, Divya, Talim, absolutely right. You got my point. And the second example here is the ectocervix. As I've told you, in females, the cervix, there are two types of cervix. Endocervix, which is columnar epithelia, and ectocervix, it's squamous epithelia. Okay, I would like to draw it again to explain you something. Okay, I'm drawing the cervix. I want to explain you something here. The uterus have columnar epithelia. We all know that. But the vagina of the female have squamous epithelia. This one is squamous. And cervix is the connecting organ between the two. So can any one of you tell me the lining of the cervix? Is it like uterus or is it like vagina? What it is? You will say both. You will say, ma'am, it's both. So let me divide the cervix into the two portions. The upper half of the cervix is endocervix. And the lower half of the cervix is ectocervix. You got my point? It's ectocervix. Right. Now the ectocervix is continuation of vagina. That's why it's squamous. And the endocervix is the continuation of the uterus. That's why it's columnar. You got, this is normal. In all normal healthy females, it's like this only. It's like this only. Now, okay, let me tell you two stress. In endocervix, as I've told you, normally it's columnar. But imagine the situation if the uterus prolapse here. If the uterus got prolapse here. So it will give a stress to the endocervix, not to ectocervix. Right? So endocervix will convert from columnar to squamous. Right? So endocervix is an example of squamous metaplasia. You got my point? And come on the contrary, ectocervix normally it's squamous. But due to increased hormones in the blood during pregnancy, during reproductive age, increased estrogen and progesterone in the blood, the squamous convert to columnar. So here squamous get convert to columnar. So ectocervix is an example of columnar metaplasia. So basically cervix is an example of both. You got my point? This is the summary of the cervix, what I have told you. Prolapse is an example of squamous metaplasia. It happens in endocervix. And cervical erosion due to estrogen exposure is an example of columnar metaplasia. Give me a thumbs up. You got my point? So this is the summary. So we are done with hypertrophy, hyperplasia, atrophy, metaplasia. The last one to be discussed here is dysplasia. Then this chapter is over. We will come on the next chapter. The last one is dysplasia. Dysplasia is important here also and in neoplasia also. So it is a very important topic to be discussed in pathology. You cannot skip dysplasia. Many students, I can guarantee here, they don't actually understand what is dysplasia. Let me explain you. Dysplasia is disordered cellular development. But you will say, ma'am, what does it mean? Technically, what does it mean? So it means there are 7 changes. 1, 2, 3, 4, 5, 6, 7. 7 changes in a cell. I will show you all 7 changes here, one by one. And after showing, I will enumerate the 7 changes. We will compare all 7. You can count there 7. Right? This is dysplastic cell. If these 7 changes happen, it will convert from normal to dysplasia. Right? So the first is increase in number of layers. Can you see here 1 layer and here multiple layer? So that is the first change. You can count the number of layers. First change is increase in number of layers. Give me a thumbs up. Increase in number of layers. Give me a thumbs up. You got it? So that is the multiple layers. Increase in number of layers. That is the first change. Right? Number 2, the disordered arrangement. Here all the cells are very orderly arranged. In normal, this one is normal, huh? And this one is dysplasia. See the 7 changes which convert normal to dysplasia. I will tell you 7 changes. The first is the increase in number of layers. You can count the number of layers. The second is the order. Here it is orderly, very beautifully orderly arranged. But here they are haphazard, here, there. So that is the second change, disorderly arrangement. The second is the disorderly arrangement. You got my point? The second one is the disorderly arrangement. So first one is the increase in number of layers. The second one is the disorderly arrangement. The third one is the loss of basal polarity. Now you will say, ma'am, what is basal polarity? First explain that. उसके बाद तो समझेगा उसका loss क्या होता है. First, what is basal polarity? Huh? What is basal polarity? So let me draw a normal cell. So this is a normal row of cell. Okay, beautifully arranged in a line, normal. So where is the nucleus? The nucleus is not in the center. It's toward the base. Normally, in you, me, everyone. Normally, the nucleus is towards the base. towards the base. It's not in the center. It's normal to have nucleus of the cell towards the base. It is known as basal polarity. Basal polarity. Polarity means pole, north pole, south pole, like it's pole. So it's towards the base pole. Base ki taraf hai nucleus. So basal polarity presents normally. If it is not present normally, now if the nucleus, can you see here, all the nucleus are present towards the base. Here, here, here. You can see all the nucleus are towards the base. So here basal polarity is present. But in dysplasia, the nucleus is present haphazard. Here, there, anywhere. It's not towards the base. So here basal polarity is lost. So loss of basal polarity is dysplasia, not its presence, its loss. Mind my words. Give me a thumbs up. You got it? Yes, yes. So that is the third change. The fourth is the pleomorphism. What do you mean by the term pleomorphism? Here all the cells are same size. I'm looking, all the cells are same size. But here some cells are small, some are medium, some are large. So change in shape and size of cell. That is known as pleomorphism. That is the fourth change, pleomorphism, right? The fifth one is NC ratio. Have you heard about NC ratio? Nucleus cytoplasmic ratio. In the first diagram, you see nucleus is very small in all of them and cytoplasm is very much. So NC ratio, the numerator is less, denominator is more. Normally it happens, right? But here in dysplasia, the nucleus become big and the cytoplasm become less. So numerator is less and numerator become big and denominator become less. So NC ratio increases in dysplasia basically because numerator increases in size. Nucleus increases in size, right? The sixth change is hyperchromatism. What do you mean by hyperchromatism? Chroma ka dictionary meaning kya hai? Chroma. The chroma's dictionary meaning is color. Color is known as chroma. Hyper means more. So it's more color. More color. The nucleus is dark color. See the color of nucleus here and see the color of nucleus here. So the nucleus are more compact, more dense, more dark. That is known as hyperchromatism. And last is mitotic activity. I can't see mitosis here, but here I can see the spindles and mitosis very frequently here. So can you enumerate the 7 changes which define dysplasia? Now don't mug them, 1, 2, 3, don't mug them. Just have a look. If it will come in the options, you automatically recognize, yes, it's one of the change of dysplasia. Give me a thumbs up if you are getting what I mean. You got my point? So can you enumerate? Help me enumerating. See, this one is normal, this one is dysplasia. Tell me the 7 changes which convert normal to dysplasia. Can you help me? Can you help me, Osama, Irfan? Can you help me, others, Talim? Anyone among you? Yes? So normally the number of layers are normal, but here number of layers is increased. The first one. Secondly, here ordered arrangement. Here it's disordered arrangement. The second one. Third, basal polarity is always present normally. But if basal polarity is lost, it's known as dysplasia. The third one. Normally pleomorphism is absent. That is all cells are same size. But here pleomorphism is present. That is all cells are different size, small, medium, large. Okay. Normally NC ratio is normal. It's less. But here NC ratio increases in size. The numerator increases. Okay. Normally hyperchromatism is absent. That is the color of the nucleus is normal. But here the color of the nucleus is dark. That's why known as hyperchromatism. Here there is no mitosis, here mitosis present. So please understand this is the definition of dysplasia. Now you can solve any MCQ based on dysplasia. You got my point? So that is all about it. So let me quickly revise the first chapter. We have done first chapter. I know it took time, but it was worth. You will get many questions based on that. So giving time to such it? Yes, Osama, absolutely correct. Yes, everyone is correct. Good going. So let me quickly revise you the 5 types of adaptation. So this one is a normal cell and you can see the 5 type of adaptations. So this is the final table we have seen. So hyperplasia, increase in number. Hypertrophy, increase in size. Atrophy, decrease in number and decrease in size. Metaplasia, transformation of one type of cell to another, either squamous to columnar or columnar to squamous. And dysplasia, you know the 7 changes. So these are the 7 changes which defines dysplasia. And you may be knowing the examples of each of them. I'm not repeating the examples. You must understand. Don't learn it, just understand. If you have something in your concepts now, you will never forget. But if you try to mug up the concepts now, you will forget in your exam. You will get confused. So try to understand the things beautifully, right? So I would like to ask certain questions, MCQs, which are basically your PYQs from FMGE exam. These are your PYQs from your last 5 years of FMGE based on this topic. You have to write your answer here in the chat box. This is the first question present in front of you. It's very commonly asked question, multiple times repeat in FMGE exam. Both hypertrophy and hyperplasia are seen in which of the following? So which of the following is an example of both? Hypertrophy and hyperplasia, only one among them. Yes, so everyone is correct. Yes, beautiful. Pregnant uterus. So pregnant uterus is an example of both. I told you multiple times and you cannot afford missing this question. If it is repeating in your exam in any language, you should be able to attend it correctly. So coming to the second question, can you tell me transformation of one type of epithelia to another type of epithelia is known as what? Is it dysplasia? Is it hyperplasia, neoplasia or metaplasia? What does it mean? So yes, everyone is right. Who is the first? Divya Reddy. Yes, and everyone else is right. Yes, very good. So the correct is metaplasia. Metaplasia. So it can be of two types, squamous to columnar or columnar to squamous. You have seen the examples also. Take care. So coming to the next question. Can you tell me the next question? All of the following are true regarding metaplasia except. So one of the following is not true regarding metaplasia. Pick that up. Pick that option. Can you tell me what is the correct answer here? So yes, again, yes, Divya, you are the first one. Very good. So slow growth, yes, all adaptations are very slow. Reverse back to the normal with appropriate treatment, yes. Once you remove the stress, they will revert back to normal. But no, irreversible thing is wrong. I told you all 5 adaptations are reversible. All 5. If you remove the stress, it is reversible. So metaplasia is one of the adaptation, one of the 5 adaptation. So it is not irreversible. It cannot be irreversible. It is reversible. And of course, in future, it can convert into cancer. This is also right. So incorrect among them is C, not D. Many students are saying D also. Don't say D. Those who are saying D, let me give you an example. Metaplasia can convert into malignancy. Can you see this? Can you see this? This is female cervix. Female cervix. The endocervix. It is columnar epithelia. Can you see this is normal female cervix? And it is columnar. I can see this one is columnar epithelia. Right? But due to HPV virus, which is a stress, if HPV virus comes in female cervix, the endocervix, causing infection. So it is a stress. So columnar convert into squamous. Can you see this is squamous? This is squamous. So metaplasia happened. This one was normal, but due to HPV virus, now it converted to metaplasia. This is a diagram of cervix of the female. Stress is HPV virus, right? Now the virus continues infecting, the lady is not taking the treatment. It continues. So metaplasia converted to dysplasia. See all the 7 features here. I enumerated the 7, you already know. Loss of basal polarity, hyperchromatism, increase. So all 7 are there. So it is known as dysplasia. If the lady is still not taking treatment, dysplasia convert into cancer. So the lady can have cervix carcinoma. You got my point? So metaplasia ultimately gradually get converted into cancer. It can happen. It can happen. Right? But at any point, if the lady is taking treatment, it can be halted there. It can be stopped there. So that is the thing. Right? Coming to the next question. So can you tell me the answer of this? I guess it's visible to your screen now. About hyperplasia, which of the following statement is false? I'm asking the false one, not the true one. Hyperplasia. What is false about hyperplasia? Is it increase in number, which is false, or increase in size? I'm asking false. Right? Yeah. What is the correct answer? Don't get confused. One of them shall be false, no? False. So plasia means increase in number, not the size. Size matlab trophy hota hai. So I will go with B. I guess everyone will. Don't get confused. Osama, others, you are getting A is not the answer. I'm asking the false statement. Come on. Hyperplasia. Plasia means number. Trophy. Don't forget. Trophy ka matlab hota hai size. Trophy matlab size. And plasia, the term plasia, word plasia means number. So hypertrophy means increase in size and hyperplasia means increase in number. Now read the question. I'm asking about hyperplasia. So plasia means number. It's increase in number. Yes, but it cannot be increase in size. So correct answer is yes, you got confused. Yes, I got it. So that's why I'm telling you, don't just jump to the answer in your exam also. What happens now? You just see the question, oh, it's my favorite topic, I know it, and you just jumped it. So in excitement, you do mistakes. Don't do that. Don't do that in your exam. Take a deep breath, calm down, read all 4 options before taking it. You don't have, you can manage the time. You have 300 questions and you can easily manage the time. You can easily manage time. So coming to the next question. Okay. Can you tell me the answer? All of the following are cellular adaptations except. Yes? Yes? So, yes, of course. You know the 5 type of adaptations. Necrosis is not a type of adaptation. Necrosis is a type of cell death. So, of course, the answer is C and you all are right. Right? So, correct answer here is C. Decrease in size is known as decrease in cell size. Decrease, not increase. Decrease in cell size. Is it atrophy, metaplasia, hypertrophy or hyperplasia? It's a very easy question, I guess. Everyone will be right. I guess it's a very easy question. Yes. So correct answer here is A. It's atrophy. You all are right. And if I change the question from decrease to increase, what is your answer now? Increase in size. Now what is your answer? What is your answer now? Increase in size. What is your answer now from the 4 options? The same 4 options. I have changed the question from decrease to increase. Increase in size is known as. Yes. In that case, your answer will become D. So trophy matlab size. The term trophy. Trophy. So increase size or decrease size. Increase size is hypertrophy. Decrease size is atrophy. Hypertrophy, atrophy. Trophy means size. You got it. I guess everyone got it. Yes. So you can get the questions like that. The first chapter is over. In this way, we are going to cover the high yielding topics from the pathology. Of course, in one day, we cannot complete all topics in pathology, but the repeatedly asked questions we will definitely complete today. Coming on the next topic, reversible, irreversible injury. So here I would like to show you only 2 diagrams. One diagram of a reversible cell, one diagram of an irreversible cell. Looking at the cell, I will help you in identifying the type of injury inside the cell. So reversible and irreversible are the 2 type of cell injuries. So this is a diagram showing reversible injury. Let me write it reversible here. And this is a diagram showing irreversible injury. Let me write irreversible here. Okay, this one is reversible, this one is irreversible. So first I will tell you changes here, then I will tell you changes here, and then we will compare back to back like this. We will compare the 2, reversible and irreversible, and you can do any MCQ based on the reversible versus irreversible injury. That's it. That's it. So let me start with reversible. It's very important. You get very simple MCQs or image-based questions based on this topic. Reversible injury. How you can identify the cell is having reversible or reversible injury? Look at the cell, right? The first thing you have to see the size of the cell. Here the cell is swelled. Can you see the swelling? The cell is swelled, right? So in reversible injury, the cell swell. The cell swell. But in irreversible injury, you know, the plasma membrane disrupts. The plasma membrane disrupts. There are holes in the plasma membrane. So all the extra fluid leak out. Leak out. So cell size is normal. It's not swelled, rather it shrink. You got my point? So see the size of the cell. The first thing you have to look at the size. If the cell swell, it's reversible. If the cell is not swell, it's irreversible. The second thing, you have to see the continuity of the plasma membrane. Here you can see the plasma membrane is continuous. It's continuous. But here you can see the plasma membrane is disrupted. Disrupted. So disruption in the plasma membrane. The rupture of the plasma membrane, defect in the cell membrane. Give me a thumbs up. So that is the second thing you have to see. The second thing. Now the third thing you have to see in reversible due to the cell swelling. When the cell swells now, on the surface blabs appear. These are known as blabs. These are known as blabs. So blabs, where it is written, let me see where it is written. Yeah, here. Blabs. Blabs is the feature of reversible injury. But once the plasma membrane disrupts now, all the blabs will disappear. Blabs will not occur in irreversible. So you can see back to back. Reversible injury, cell swells, plasma membrane continuous, and blabs are there. But in irreversible, the plasma membrane disrupts. So holes are there. So extra fluid leaks out. So no swelling, rather it's shrinkage you can say, or normal size, but it's not swelling, and there are no blabs. No swelling, no blabs. It's irreversible. So based on that, we can decide. Now I'm going to cover 4 organelles here and 4 organelles there. What are the 4 organelles? I will compare the endoplasmic reticulum of both of them. I will compare the ribosomes of both of them. I will compare the mitochondria of both of them. And I will compare the lysosome of both of them. Based on these 4, I will help you in deciding whether it's reversible or irreversible. In the end, I will give you a table. Don't worry, first understand. The first thing is endoplasmic reticulum. Can you see the endoplasmic reticulum here in this cell? This one is reversible, huh? So you see the endoplasmic reticulum, it's swelled. Everything is swelled here. In reversible, the cell swell, endoplasmic reticulum swell. So it's swelled. It's swelled here, right? That's endoplasmic reticulum. See the mitochondria here. Can you see the mitochondria? Inside the mitochondria, I can see small densities. So mark the word small densities in mitochondria. In reversible, small. वहाँ पे large होंगी. In irreversible, there will be large densities. But in reversible, it's small densities. You got my point? See the ribosomes. You know, ribosomes are stick on the endoplasmic reticulum. It is known as rough endoplasmic reticulum. Ribosomes are present on the surface of the endoplasmic reticulum. But in reversible injury, they just leave. They just leave endoplasmic reticulum and become free in the cytoplasm. This is known as dispersion of the ribosome. So dispersion of the ribosome taking place. The third thing, right? And lastly, the lysosomes. Can you see this yellow one? This is a lysosome. What do you mean by lysosome? Lysosome is something when it is activated, it eats own cell organelles. So can you see lysosome is eating own mitochondria. अपने ही mitochondria को खा रहा है वो. So it is known as autophagy. So can you tell me the four organelles, what it is there in the reversible? So you will say, ma'am, endoplasmic reticulum is swelling, number 1. Mitochondria में small density, number 2. Ribosome में disruption, number 3. And lysosome में autophagy. Let me show you the same four organs in irreversible. Are you people still there or sleeping? Give me a thumbs up if you are awakened. Are you there? Can I continue? Yes. Are you there? So in irreversible, the same four organelles I am showing now. So start with endoplasmic reticulum. In reversible, the endoplasmic reticulum was swelled. Here the endoplasmic reticulum is lysed. Lysis of the endoplasmic reticulum is there. Right, number 1. Lysis is there. Okay. Number 2, in reversible, in mitochondria, the densities were small. But please see the densities here. The densities are large densities. It's not small. Large amorphous densities, you can say. Number 2. Number 3, ribosomes are same. There also the ribosomes were dispersing. Here also the ribosomes are dispersing, no change. And the last one is lysosomes. Their lysosomes were showing autophagy. Here lysosomes also rupture. Can you see the rupture? The ribosome is ruptured. So everything is ruptured here. So these are the four organelles we have compared back to back. And the last thing we have to compare here is the nucleus. See the nucleus here and see the nucleus here. The last thing we have to compare in the both is the nucleus. In reversible injury, nucleus shows only one thing, clumping of the nucleus. The nucleus got clumped. Can you see? Small clumps, gatte ban gaye, clumps ban gaye andar. Chromatin got clumped. So that is reversible. But in irreversible injury, it's not clumped. It shows three things, pycnosis, karyoraxis, karyolysis. Now you will say, ma'am, what does it mean? What is pycnosis? What is karyoraxis? What is karyolysis? So see, I will show you here all three things. In normal cell, the cytoplasm is pink and the nucleus is blue. Do you know that? I guess everyone knows it. In normal cell. Right. So in irreversible injury, three things happen one by one. First, the nucleus condensation of the nucleus. Condensation or shrinkage of the nucleus. So nucleus become more blue color, dark blue. It is known as pycnosis. Pycnosis means dark, more dark. As compared to normal, it's more dark. It is condensation of the nucleus or shrinkage of the nucleus. The second, the nucleus got fragmented. Fragmentation of the nucleus into multiple pieces. It is known as karyoraxis. Raxis ka matlab hota hai pieces, multiple pieces. And the third thing, the nucleus is losing its blue color. The nucleus, can you see? The nucleus is losing its blue color. It is known as loss of basophilia. Basophilia means blue color. Basophilia is lost. It is known as karyolysis. Give me a thumbs up. So these three things happens in irreversible injury, not in reversible injury. So can you do a back-to-back comparison in both? Can you do a back-to-back comparison? Please everyone help me in comparing that. We have understood the two types of injury, the reversible, the irreversible. Can you help me in comparing? So tell me the cell, here it swell, here it do not swell. Here the plasma membrane is intact. Here the plasma membrane has small holes. Here blebs are present. Here blebs are absent. Say yes. Now compare the four organelles in both ways. Here also, there also. What about endoplasmic reticulum? In reversible, it swells. In irreversible, it lyses. Ribosome shows disruption in both of them. No confusion. It's same. Mitochondria here shows small density. Here it shows large density. Mitochondria. And lysosome, here it shows autophagy. And here it shows rupture. Come on, the nucleus. The last thing to be compared here is the nucleus. Here nucleus show one thing, clumping. Here nucleus shows three things, pycnosis, karyoraxis, karyolysis. Now based on this, you can solve any question based on the injury, cell injury. Everyone give me a thumbs up. We will solve some questions based on this concept. I guess everyone understood now. So please, can you help me in answering this question? Anyone among you? Can you help me in answering this question? Which of the following is the characteristic of irreversible cell injury? I am asking which happens in irreversible. Only in irreversible, not in reversible. What will be the correct answer here? It's a tricky question. Easy but tricky. So rule out the options one by one. Yes, most of you are right. Very good. Cell swelling? No, it happens in reversible. Disruption of ribosome? You will say, ma'am, it happens in both. Reversible plus irreversible, but it's not characteristically only for irreversible. So I will not go with this also, right? Amorphous density in mitochondria, again, it happens in both. In reversible, small densities, but in irreversible, large densities, but it happens in both. So I cannot say it is specific or peculiar for irreversible, but yeah, I'm sorry. I got confused. Swelling of the endoplasmic reticulum, again, it happens in reversible, not irreversible. But I'm sorry, this option, I guess this one, it's amorphous. Amorphous means large. So amorphous large densities occurs in irreversible, not reversible. So I will go with B. I will go with B. Yes, you all are right. I got confused. So yes, the correct answer here is B. Done? Can we go ahead? Can we go ahead? Can you tell me the next question? It's very easy. Cell swelling with blebs and myelin figure. It's seen in where? Three things are given to you. Number one, cell should be swelled. Number two, blebs should be present. And number three, myelin figure should be present. It happens in reversible or irreversible or metaplasia or anaplasia. We have seen metaplasia. It's the transformation of one epithelia to another. No, it's not that. Anaplasia is neoplasia, malignancy. No, it's not that. So what among the reversible and irreversible? Blebs and swelling present in reversible, not in irreversible. We have seen. Myelin figures, I forgot to tell you, it also happens in reversible. So go with A and you all are right. Very good. And you are, you may be surprised. These are the PYQs of FMGE. Those who have solved the PYQs, they may be knowing that. Right. So I have taken the 5-year PYQs. Right. So you will be able to solve it. So can you tell me the next question? Which of the following is not a feature, not a feature of irreversible injury? Which doesn't happen in irreversible? Is it pycnosis, karyoraxis, karyolysis, or bleb formation? What doesn't occur? So everyone is right. Bleb formation, because bleb formation is a feature of reversible injury. It never happens in irreversible. But remaining three things happens in irreversible injury in the nucleus, one by one. So I will go with D and you all are right. Fantastic. Great. I'm happy that you got the concept. So we are done with chapter 2 also. Coming on the next chapter or next topic, you may say. So the next topic, the ultra super duper important topic I'm going to teach you is the cell death. Can I start the cell death? There are two types of cell death. Apoptosis, necrosis. Now, why the cell is having two choices of dying? Do you have two choices of dying? Yes, of course, you also have. So either someone can suicide for dying or someone can have a murder for dying. So in the same way, the cell also have two options, suicide and murder. In both of them, ultimate the cell will die. But one is due to suicide, one is due to murder. I will explain you why I am calling them suicide and murder. If you can compare it now, like in a simplified language, suicide and murder, you will never forget. Yes. So yes, every year, Isaac, one question comes on apoptosis or necrosis. So one question I am leaking. It is in your paper. Either from apoptosis or necrosis, I don't know. Which exact question, I don't know. But the certain thing is that you will get one question from this topic. Every year it comes. Every year. So this topic is going to be ultra super duper important. So it is worth to give 10 to 15 minutes to this topic to secure one MCQ in your pocket. Right. So let me start with apoptosis. The two type of cell death, apoptosis. As I have told you, apoptosis is like cell suicide. What do you mean by cell suicide? Why a cell wants to do suicide? No one want to do suicide. No, I don't want to do suicide. You don't want. Why a cell want to do suicide? Why? There can be two possibilities. Number one, in the body, there is a cell whose function is completed in the body. There is no another function of that cell in the body for the purpose for which that cell is formed, that is fulfilled. So cell will think that I don't have any purpose in life now, I should commit suicide. I don't have any function right now. I have completed my function. Okay? So that the cell can suicide. Number two, the nucleus or the DNA of the cell is damaged too much and it cannot be repaired. Imagine a person who is too severely diseased and cannot be treated. So the person will, now I cannot be treated, I must commit suicide. In the same way, the cell will think my DNA is damaged too much, I cannot be repaired now. So I will commit. So these are the two reasons the cell will commit suicide. So basically, these are the two reasons for which apoptosis takes place. Now, how does the cell will commit suicide? How does a cell will commit suicide? Just suppose this is a cell. Now, either its function in the body is over or the nucleus is damaged too much that it cannot be repaired. So this cell will think, I must commit suicide. So inside all cells, all human cell, there is an enzyme. The name of that enzyme is caspase. Don't forget, caspase is the heart of apoptosis. But normally the caspases are inactive. Inside my cell, your cell, everyone have caspase. But currently my caspase are inactive, your caspase are inactive, right? But if any cell that the cell want to do the suicide, want to commit the apoptosis, so caspase will be activated. The caspase will be activated. Once the caspase will be activated, what they will do? Caspase will degrade three things. What three things? Inside the cell, there is nucleus. Inside the cell, there is cytoplasm. And inside the cell, there is cell membrane. So all these three things will be degraded by the caspase. What three things? Nucleus, cytoplasm, and cell membrane. All that will be degraded into multiple pieces. Nucleus into multiple pieces. Cytoplasm into multiple fragments. And plasma membrane also into multiple pieces. It is fragmented into Now, the complete cell is converted into multiple small bodies known as apoptotic body. Now, each body contains all three things. A small amount of nucleus, a small amount of cytoplasm, and a small amount of plasma membrane. So, it is packed into multiple bodies. The main point to be understand here, there is no leakage outside. Even not a single drop of the cytoplasm or nucleus part or plasma membrane part is leaking out. No, everything is packed into the imagine if someone is committing suicide. Imagine if any human being, I don't want to commit suicide. If I want to commit suicide, what happened? I will not take a mic and announce everywhere I am committing suicide. A suicide is committed in personal space, privately, right? In the same space, in the same thing, here cell is not leaking outside anything. No leakage, no information. Chup chop, silently, the cell is converted into apoptotic bodies. That's why it is known as suicide. No one is knowing about that. Right, that's why it is known as suicide. Give me a thumbs up, you got it. And ultimately, the cell got converted into multiple bodies. In the end, a phagocyte will come. And phagocyte will engulf all the apoptotic bodies, eat all the apoptotic bodies or engulf all the... So the cell is disappeared from the world. The cell has disappeared. Basically, the cell have done suicide because no one knows about it. No one knows. It was silently without any leakage. Since there is no leakage, so no inflammation. No inflammation. Whenever anything happens in human body, the inflammatory cells come first. Ki kya hua? We will do the repair. What happens? So here, no leakage, no inflammation. That is the hallmark of apoptosis. And the reverse will take place in necrosis. Necrosis is murder. Just suppose someone is murdered. So what the person will do? The person will shout, help, help, help. So it is calling everyone for helping. So in the same way, in necrosis, leakage occurs, inflammation occurs. But here, no leakage, no inflammation. Here, plasma membrane don't disrupt. Plasma membrane just converted into apoptotic bodies. But in necrosis, plasma membrane burst. It's ruptures. So everything leaked out. So all the population will come. All the neutrophils, inflammatory cells will come. That's what happened. It's like murder. You got my point? वो ढिंडोरा पीट के होगा, ये silently होगा. This one is silent. And that one by shouting. So that is apoptosis, necrosis, suicide, murder. Now you will never forget the process of each of them, I guess. Say yes. Say yes. So what is the definition of apoptosis? Currently, I am teaching you apoptosis. After that, I will come on necrosis. Apoptosis is a type of cell death. It is a type of cell death in which the cell which want to commit suicide, that will activate an enzyme known as caspase. The caspase will convert the cell into multiple apoptotic bodies, and those apoptotic bodies will be phagocytosed. A phagocyte will come and eat them. So there is no leakage, no inflammation. That is the hallmark. That is the hallmark of apoptosis. No leakage, no inflammation. It suicides silently, personally, privately. You got my point? Can we go ahead? Can we go ahead? Okay. You got it? What is apoptotic body? Easy learning. I told you, apoptotic bodies, each of them contains a small portion of nucleus, a small portion of cytoplasm, and a small portion of plasma membrane. That is the apoptotic body. Now, the most important thing you must ask me here, ma'am, how does the caspase activated? After the caspase activated, we got it converted into apoptotic bodies and the phagocytosis will happen. But how does the caspase activate? So what is the mechanism of apoptosis? Caspase can be activated by two mechanisms, extrinsic and intrinsic. Now, multiple MCQs come from the mechanism. You must understand the mechanism. Now, I will super duper simplify this concept for you. Believe me, give me just next 2 minutes, you will be master over apoptosis. Okay. So there are two pathways, the intrinsic and the extrinsic. Now, each of the pathway have two phases, initiation, execution, initiation, execution. Now, listen my point. Why extrinsic is known as extrinsic? Because here the signal for the cell that you have to die, this signal comes from outside. That's why it is known as intrinsic. And here the signal will come from the inside the cell. Signal will come from the inside the cell. Imagine this is a cell. This is the nucleus of the cell, right? Now, if someone else is giving this signal to this cell that you have to die now, so it is extrinsic pathway. Signal is coming from outside. And imagine if the nucleus of this cell is damaged and it cannot be repaired. So nucleus will give signal to the cell that I am damaged, I cannot be repaired, you commit suicide. So this signal is coming from inside. So it's intrinsic pathway. I guess you got it. The meaning of the extrinsic and intrinsic, the first thing. Now, both of them have 2 phases. Both of them have 2 both of them have two phases, the initiation, execution, initiation and execution. Now, initiation phase is different for both of them, but execution phase is common for both of them. So, I'm going to tell you 3 movie stories now. 3 movie stories. Listen, the first story I'm going to tell you initiation of extrinsic. The second, I will do an interval here, right? The second story, I will tell you the initiation of intrinsic, right? And after that, I will tell you a common movie. So, continuing from here interval and here interval, the third story will be the execution, which is common for both. Are you prepared for that? Can we go ahead? So, starting the first story. The first story, the extrinsic pathway, the initiation phase of extrinsic pathway, right? How does it happen? Now, listen, can you all see a cell? Give me a thumbs up if you all can see a cell. Yes, give me a thumbs up. So this is a cell. You can see the nucleus of a cell. Inside the nucleus, you can see the double-stranded DNA of the cell. On the surface of the cell, what is this red color thing? The red color thing are the death receptors. We all have cells, and inside our cells, the cells of our body, they have death receptor, but they are inactive. The receptors are present. Now, death receptor, the most important death receptor is FAS or CD95. Learn it. Many times MCQs come on it. FAS or CD95 is the name of this red colored death receptor. Right, so death receptor. Now, the signal is coming from outside in the form of the ligand. This yellow color is the ligand. It is a signal. It is coming and giving the signal to this cell that you have to die now. You have committed your function. You are no more required in this world. You must commit suicide. You are not important now. So, this signal is coming in the form of the ligand, the fast ligand. So, the fast ligand is coming and binding with the fast receptor. Let me zoom out, right? So, I'm zooming out. Can you see the fast ligand is coming and binding with one of the fast receptor? One of the fast receptor. Normally, the fast receptors are at a distance from each other. You can see they are at a distance from each other. But when this ligand is coming and binding with the death receptor, the fast receptor. So, can you see here it is binding? So, multiple fast receptors come together. They got activated and they come together. Multiple fast receptor, they come together, and because of which a domain is formed. This is known as domain. The multiple fast receptors, the death receptors coming together, CD95 receptors coming together because of the ligand, and a domain is formed. This domain is known as FADD, fast associated death domain. What it is known as? What it is known as? Say it out. Fast associated death domain. Now, in the cytoplasm of the cell, multiple caspase are present. Caspase 1, 2, 3, 4, 5, 6. There are many caspase, but they are all inactive. Because of the formation of this FADD, the first caspase which become active is caspase 8. It's the most important MCQ. So, pro-caspase 8 convert into active caspase 8. So, the first caspase which get activated in extrinsic pathway is caspase number 8. This question comes repeatedly in your exam. You can understand now. And CD95 or death receptor or FAS is associated with extrinsic pathway. I am teaching you extrinsic pathway. Right. So, extrinsic pathway. In extrinsic pathway, the first caspase which got activated is caspase number 8. Okay. Here is the intermediate. The same is from the Robbins, the same diagram, right? Which I have simplified like this for you. So, if I show you this diagram, you will feel trouble, ma'am, what is it? But in this diagram, I guess you are getting it, right? So, same diagram. So, you can see this is the death receptor. You can see the ligand is coming and multiple death receptor come together, because of which FADD is formed and is causing activation of caspase 8. So, the same diagram, right? The same we can write like this. So, there is an intermission. So, initiation is over. You will say, ma'am, what happened ahead? आगे क्या हुआ? इस caspase 8 का क्या करोगे आगे? वो मैं बाद में बताऊंगी. I will tell you later on. Let me just make a hold here. Let me tell you initiation of intrinsic pathway now. Initiation of intrinsic pathway, then we will continue in execution. So, coming on the intrinsic pathway initiation phase. Here, it's intrinsic now. Signal will come from inside. Signal. So, what is the signal here? DNA damage. Can you see a cell? Say yes. You can see the nucleus? Say yes. Inside the nucleus, can you see a double-stranded DNA? It's healthy. Currently, it's not damaged. It's healthy. And this is the mitochondria of the cell. Mitochondria have two membranes, inner membrane and outer membrane. And between the two membranes of the mitochondria, there is a protein known as cytochrome C. Here, it is the heart of intrinsic pathway, cytochrome C. It never comes in the cytoplasm. It is present between the two membranes of the mitochondria. You got my point? Now, imagine, this is normal, happens in me, you, everyone, it's like this. But imagine, now let me zoom it out a little bit. As I have told you, the cytochrome C never comes out. So, you will say, ma'am, who is stopping the cytochrome C to come out? Mitochondria have a door now. Can you see the door of the mitochondria? This is known as mitochondrial transit. Transit means the door in the mitochondria. You can ask me, ma'am, why the cytochrome C not coming out of the door? Because on the door, there are three guards, you can say. Guards yani chowkidar. You know, 3 darban, chowkidar baithe hain yahan. They are preventing cytochrome C. No, you cannot come out, you go inside. So can you name the 3 guards? The 3 guards. It's BCL2, BCLX and MCL1. You can't forget it. Please, please. So it's BCL2, BCLX and MCL1. These are the 3 type of guards which are preventing cytochrome C to come out. No, you go danda leke khade hain ki andar jao, you cannot come out, you cannot come out. So they are preventing apoptosis. That's why these 3 guards are known as anti-apoptotic proteins. Learn the 3 guards, the 3 anti-apoptotic proteins. They are preventing apoptosis. Till now, DNA is healthy. It's not damaged. Now imagine a situation, the DNA is damaged. Oh my God, the DNA is damaged. The DNA is damaged, it cannot be prepared. So this DNA will give the signal to the mitochondria, I am damaged. You start the process of committing suicide. We cannot survive now. You start the process. So the signal is coming from inside, mind it. It is not coming from outside in the form of a ligand like previous one. No. It's coming from inside. That's why it's intrinsic pathway. You got my point. Now, as soon as the mitochondria receive the signal, what the mitochondria will do? It will replace the guard. These guards are replaced by this one, right? So BCL2, BCLX, MCL1, they are replaced by BARCs, BIM and BAD. These were the guards, they do not open the door. And these are the guards, they will open the door. They will open the door and say, jao, jao, bahar jao. You want to go out? You just go out. So they will open the door and they allow the cytochrome C to come out. So basically, they are helping the apoptosis. That's why known as pro-apoptotic proteins. Pro-apoptotic. These are anti-apoptotic proteins and these are pro-apoptotic. So initially, anti-apoptotic proteins were there. But on receiving signal, they are replaced by pro-apoptotic proteins. Pro-apoptotic protein will open the door and cytochrome C will come out. Can you see? The cytochrome C will come out. After coming out, there are many caspase now, 1, 2, 3, 4. So because of cytochrome C, the first caspase which is activated is procaspase 9. Procaspase 9 converted into active caspase 9 because of cytochrome C. So here in intrinsic pathway, caspase number 9 is the first caspase which got activated. You got my point? You got my, so same you can write here like this. So on receiving the signal is the DNA damage. The anti-apoptotic are replaced by pro-apoptotic. You must learn the name of the anti-apoptotic. You must learn the name of the pro-apoptotic. And because of which the door is opened, the cytochrome C will come out and it will cause the activation of caspase 9. So we ended here with caspase number 8 and we ended here with caspase number 9. You will ask me, ma'am, aage kya? What happens ahead? What happens to this caspase 8 and what happens to this caspase 9? Let me continue the 2 stories together in execution pathway. Right. So the third story, the last story is the execution, which is a convergence point of the both. Say yes. So here caspase number 8. And here caspase number 9. Here along with 8, 10 sometimes also happen. In the latest addition, the 10th addition of the Robbins, 10th is also, caspase number 10 is also added here. So in extrinsic, learn 2 caspase, 8 and 10. And in intrinsic, learn only 1, it's 9. So these 3 caspase activate the next 2 caspase 3, 6, 7. So these are the caspase of the execution pathway and ultimately all the caspase will get activated. Once all caspase are activated, the cell is converted into apoptotic bodies. In the end, a phagocyte will come and engulf all the apoptotic bodies and the apoptosis is over. You got my point? So can you give me 3 answers? Can you tell me the name of the caspase in intrinsic pathway? Can you tell me the name of the caspase in the first caspase which is activated in extrinsic pathway? And can you tell me the name of the caspase which is active in execution pathway of both intrinsic and extrinsic? Can you give me 3 answers? Most commonly asked MCQs. So in intrinsic, the answer will be 9. Yes. In extrinsic, the answer will be 8. And in execution, 8 and 10. Here in execution, it's 3, 6, 7. I guess you all know the answers. So please learn the 3 answers. If I tell you this directly now, you will get confused. But now you know the story. You can correlate. Right? So this is the thing. Everyone is comfortable? Can we move ahead? So that is all about the mechanism of apoptosis. Before ending apoptosis, I would like to tell you one more thing. The morphological changes in apoptosis. There are 6 morphological changes in apoptosis. In the sequence you have to learn. This is a normal cell. Can you all see? Yes, it's a normal cell. As soon as this cell commits suicide, that is undergo apoptosis, the first thing, this cell shrink in size. See, the cell shrink. I have shown you, see the size. The first thing, it shrink in size. So it's a very important MCQ. Listen, a very important MCQ. The earliest change in apoptosis, go with cell shrinkage. The earliest change in apoptosis, what is the correct answer? I'm sorry, it's cell shrinkage, right? The earliest change. The second thing is the eosinophilia, right? See the cytoplasm here, because the cell is shrinking now. So all the organelles come closer. So all the mitochondria, ribosome, endoplasmic reticulum, they come closer, closer, closer. क्योंकि जगह कम है, there is less space now. So the cell will look more pink. So that's why eosinophilia. You got my point. The second thing. The third thing, the nucleus got condensed. Can you see the nucleus got condensed? More blue. I'm really sorry. Give me a minute. I'm really sorry. The third thing is the pycnosis. That is condensation of the nucleus. The nucleus got condensed, right? More blue. The fourth thing, the nucleus got fragmented. It's known as karyoresis. Or you can include the both nuclear changes in one. So first is cell shrinkage. The second is eosinophilia. The third is the nuclear changes. That is pycnosis and karyoraxis. The fourth thing is the blabs. On the surface, the blabs will appear. The fourth thing is the blab. The fifth thing is the apoptotic bodies. Now, the cell will convert into apoptotic bodies, and lastly a phagocyte will come. Can you see a green color cell? Phagocyte is coming and engulfing all the apoptotic bodies. Can you enumerate the six? Can you enumerate the six with a line? Can you enumerate? Can you help me in enumerating the six, anyone? In a sequence, the first one is cell shrinkage, the earliest one. It's the cell shrinkage. The second one, after cell shrinkage, it's eosinophilia. Eosinophilia. What is the third one? It's nuclear changes. The nuclear changes pycnosis and karyoraxis. The fourth one is the blabs. After blabs, apoptotic bodies are formed. And in the end, phagocytosis happens. So never forget. So two questions are asked here. The earliest change, go with shrinkage. But the pathogmatic change, the specific change or pathogmatic change, go with nuclear changes, pycnosis or karyoraxis, whatever given in the option. So earliest is shrinkage. But the specific or pathognomatic change is the pycnosis and karyoraxis. You got the two MCQs here covered. Everyone give me a thumbs up. Everyone give me a thumbs up. Yes, TNF is also involved in extrinsic pathway. In case of CD95 fast, there can be TNF. You are right. Can we go ahead? Okay. So you can see, can you see this cell? Here, let me mark. This cell. This cell is smaller than the others. So cell shrinkage. This cell is more pink as compared to all others. So can you see this cell? This cell. It's smaller and more pink. So cell shrinkage is there and eosinophilia is there. Both thing is there, right? Can you see here? This is pycnosis. This is karyoraxis. Can you see blab formation in electron microscopy? This is a normal cell. When it converted to apoptotic cell, appreciate the blabs. Can you appreciate the blabs on the surface? Please appreciate. These are blab formation, right? After blab formation, the next is the apoptotic bodies and they are phagocytosized, right? So we are done with the six morphological changes in a sequence. Now coming on the diagnosis of apoptosis. There are two ways of diagnosing apoptosis. Do you know it? Both are MCQs, PYQs. दोनों पे PYQ है. Only two ways of diagnosis. Number one, there is a marker for apoptosis. Just suppose I'm showing you this slide and asking you, can you identify the apoptotic cell? So you will see, ma'am, the cell which is smaller, which is more pink, which is having pycnotic nucleus, that will be apoptotic. But few of you may be having trouble. Ma'am, I cannot identify. I'm confused between this and this or this. Which one of them is apoptotic? It can happen sometime to me also. So what happens now? There is a marker, specific marker of apoptosis. The name of the marker is annexin 5. Annexin 5. It comes in the form of a liquid in a bottle. So I will take the slide. I will spread the liquid over the slide. Be it there for 5-10 minutes and then wash it. And then look the slide under microscope. So only apoptotic cell in the entire slide will take the brown color. That is annexin 5. Others will not take. So that is a specific marker. Only apoptotic cell is highlighted with annexin 5. Others are not highlighted. Give me a thumbs up. So annexin 5 is the marker number 1. And number 2. Do you know what is electrophoresis? In biochemistry, you may have read now. What is agarose gel electrophoresis? क्या होता है? Agarose gel electrophoresis क्या होता है? What does it mean? Agarose gel electrophoresis. Okay. This is a normal cell. This is the nucleus of normal cell. But this is a apoptotic cell. In apoptotic cell, I told you in the nucleus, fragmentation happens. Karyoraxis. So if I do the electrophoresis of this cell, so the complete nucleus will be there in one row. Because nucleus is not fragmented, no? It's in one row. But if I do electrophoresis of this cell, it will be like this. Because the nucleus is fragmented into multiple pieces. That it will be the electrophoresis, the bands of the electrophoresis will be like this. So because the nucleus is fragmented, obviously. So looking at the bands of the electrophoresis like this or like this, I can decide whether it is a normal cell or a apoptotic cell. Give me a thumbs up. Now this pattern is looking like a ladder. You know what is ladder? Hindi में कहते हैं सीढ़ी. सीढ़ी के जैसा लग रहा है. So this is known as step ladder arrangement. It's an MCQ. Step ladder arrangement. Give me a thumbs up. Yes. So there is step ladder arrangement. because of the carrier axis. Can you see? Can you identify which of among the following 4 cells? 1, 2, 3, 4. Which is apoptotic? I guess this one is apoptotic. I can see a step ladder pattern. I can see a step ladder pattern. Say yes. So this is peculiar step ladder pattern in apoptosis. So these are the 2 ways of diagnosing apoptosis. We are done with apoptosis. Apoptosis means suicide, which is one type of cell death. The another type of cell death is necrosis, is murder. I'm starting necrosis now. But before coming to the necrosis, you must understand the differences between apoptosis and necrosis. Right? If someone is committing suicide, I guess the person will do suicide alone now. I cannot take the complete everyone do suicide with me. No, I cannot do that. So suicide occurs of a single cell. That is, apoptosis occurs of a single cell. But if someone is doing murder, so with the gun we can hit the multiple person at a time, right? So murder can be done of a multiple person at a time. You can understand like that. So necrosis occurs of multiple cells together. So apoptosis occurs of one cell, but necrosis occurs of multiple, a group of cells. Give me a thumbs up. If you understand with suicide and murder now, you cannot forget the differences. So suicide, one cell, but murder, multiple cell, group of cell. In apoptosis, the cell shrink. The cell shrinkage was the earliest sign. I told you. I shown you diagram also. So it is the cell shrinkage, but in necrosis, the cell swells. Here cell shrinkage, here cell swells. In apoptosis, the nucleus is pycnosis carrier axis, and necrosis also, it's pycnosis carrier axis. It's same, not different. But here in apoptosis, cell membrane is intact. Till end, it's intact. So no leakage, no inflammation, nothing. No leakage, no inflammation. But in necrosis, the cell will burst. The cell will burst. It will shout, help, help, help. I'm murdered. Please help. Right? I'm being murdered. So it is a cell disrupt, the cell membrane burst. So cytoplasm leakage present, inflammation present. Here the 2 things are absent, here the 2 things are present. Now you will never forget. You can see the back-to-back comparison, beautiful diagram from Robbins, the back-to-back comparison of the 2 types of the cell death. Can you see? This cell, see this cell. What is happening? This cell is swelled. First it is swelled. The blebs are formed. It is swelled. Whenever the cell swell, the blebs will occur. So blebs are formed. Then multiple apoptotic bodies are formed. In the end, a phagocyte is coming and engulfing all. So no leakage, no inflammation. I cannot see a neutrophil here. Right? But on the contrary, see this cell. This cell. This cell is shrinking in size. Right? It's shrinking. And the cell membrane is bursting. So neutrophils are coming. So inflammation present, neutrophils present. Here inflammation, neutrophils is absent. You got it? So that is all about apoptosis. We will solve some PYQs on apoptosis and then move to the necrosis. Can we? Can we? Please, I want everyone, each and every who is awakened and who have understood the topic completely to participate in the answers. At max, you will be wrong. Nah, it's okay. Trying is important. So the first question is in front of you. Right? So this is a question from the last to last year FMGE exam. CD95 is a marker of. So is it intrinsic pathway or extrinsic pathway of apoptosis? It is a marker of what? So someone is saying B, someone is saying A. Oh my God, why you people are confused? CD95 is the another name given to FAS. FAS ligand, the death receptor. The death receptor, FAS receptor, the death receptor. So death receptor were important in extrinsic pathway, not in intrinsic pathway. In intrinsic pathway, it was cytochrome C, not the death receptor. So yes, the correct answer here is B, not A. Those who are saying A, they got confused, I guess. But if I change the question, instead of CD95 or FAS, I ask you question, cytochrome C is a marker of. Cytochrome C in the mitochondria is a marker of. Then your answer will become A. Cytochrome C is involved in intrinsic pathway. So you can answer this only if you know the mechanism. Yes, instead of FAS, if I ask the TNF, again it will be extrinsic pathway. TNF also involved. So correct answer here is B and you all are right. Can you tell me the next question? The next question I already told you. You tell me. In apoptosis, cytochrome C, after leaking in the cytoplasm, it will act through what? I forgot to tell you this thing. I guess you may be knowing. I told you that cytochrome C, after coming in the cytoplasm, it activates caspase 9, the first caspase. But it activates caspase 9 via APOF1. The full form of APOF1 is apoptotic activating factor. Apoptotic activating factor, APOF1. Because of which it will activate this thing, caspase 9, right? So the next question, can you tell me which among the following is the anti-apoptotic gene? Anti is one of the guard which closes the door of mitochondria. The one which closes the door. Kaun karta hai close? I told you 3 names which closes and 4 names which open. I've told you the names. So is it BARX, BARD, BCLX or BIM? So most of you are right. Very good. It's BCLX, right? It's BCLX. So I told you the 2 type of guards, anti-apoptotic and I told you pro-apoptotic, right? These were present on the transit of the mitochondria. The anti-apoptotic are the one which closes the door. So they do not allow cytochrome C to come out. The pro-apoptotic are one which opens the transit, which opens the door, and they allow cytochrome C to come out. That's why they cause apoptosis. I told you 3 examples here: BCL2, BCLX, and MCL1, right? But here I told you 4 examples: Box, Bath, BIM, and BARC. Don't forget, many MCQs come on that. Now have a look at the question. You can answer it correctly. Those who have not answered yet, they can also answer it correctly. So what is the correct answer here? The correct answer here is BCLX. Can we go ahead? Can we go ahead? Yes. Okay. Okay. So coming to the next question. What is the earliest change in apoptosis? Who will tell me the correct answer? The earliest one. Is it cell shrinkage or pycnosis or formation of apoptotic bodies or fragmentation of the cell? What is the earliest one? You all are right. Earliest one is the cell shrinkage. Can you arrange them in a sequence? Fastest finger first, KBC. Can you arrange them in a sequence from earlier to later? इन सभी जो इवेंट्स हैं इनको आगे से पीछे की तरफ एक क्रम में लगाओ in their sequence in which they occur. Can you arrange man? So Abhi is saying ABCD. Rani is also saying ABCD. Divya is saying ABDC. Is it ABCD or ABDC? What you want to say? What is the correct answer? ABDC. ABDC or ABCD? What is the correct sequence? So first is cell shrinkage, I know. Then there is pycnosis, number 2. Then karyoraxis, number 3. And last mein formation of apoptotic. I have shown you the sequence. So it will be ABDC. Right? You can imagine how beautifully I can create the MCQs on that, giving you 4 options like. So correct answer is ABDC. All those who are ABDC, they are right. You got my point. So let me move ahead. The correct answer here is cell shrinkage. Let me change this question. Instead of earliest change, I am asking the most specific change in apoptosis or pathogmatic change in apoptosis. From the 4 same options, what is your answer now? Pathognomatic feature, specific feature, not earliest. What is your answer now? Yes, you will go with pycnosis as well as karyoraxis may be correct. So B and D both will be correct. Yeah, B is more correct, you can say. Yes, yes, you all are right. Good, great, good going. So the next question is in front of you. Can you tell me the characteristic feature which is true for apoptosis? Which among the following is true for apoptosis? In apoptosis, cell membrane intact, is it true? Or cytoplasm become basophilia, is it true? Or nucleus molding occur, is it true? Or cell swelling occur, is it true? Or if everything is true, what is the characteristic feature? What you will say? What you will say? So, no, cell shrinkage occurs, cell swelling do not occur. Cell swelling occurs in necrosis, but in apoptosis, cell shrinkage. Nucleus molding don't occur. It's nucleus pycnosis and nucleus karyoraxis which occur, but molding don't occur, right? Cytoplasmic basophilia, no, don't occur. It's the nucleus basophilia which occur. Cytoplasmic basophilia not occur. Cytoplasmic eosinophilia occurs because of the condensation, cell shrinkage, the organelles come closer. So the cytoplasm become eosinophilic. But it's not basophilic. But nucleus membrane intact, yes. The nucleus membrane intact, no leakage, no inflammation, it is the hallmark. So correct answer here is A. Yes, everyone is right. Very good. Everyone is right. So coming to the next question, read it carefully. Don't jump. It is a tricky one. Don't jump. Read it carefully, then tell me the answer. All of the following are the features of apoptosis except. The question includes except. Don't miss it. So what is the correct answer now? Can you tell me the correct answer? Anyone among you? What is the correct answer now? Yes. So except. The question contains except. Cell swelling is not a feature. Cell swelling is a feature of necrosis, not apoptosis. Yes, I will go with A. But nucleus compactation occurs now. Why you are saying B? Who is saying B? Mupannini. Why it is you are saying B? B is correct now. Nuclear compactation is the another name given to pycnosis. And I guess pycnosis happens in apoptosis. Intact cell membrane, it also happens. And cytoplasmic eosinophilia, it also happens. So remaining 3 options happens in apoptosis. But the first one do not happen. So I will go with A. Yes, have you got it? So give me a thumbs up. The correct answer here is A. So this is how you will get, this is the easiest question. I guess no need to launch. Everyone knows the answer. Annexin 5 is a marker of repeatedly asked question. Easiest one. Annexin 5 is a marker of apoptosis. Easiest question. I'm not asking even this question. So we are done with apoptosis, the suicide. Let me come on the murder, necrosis. More interesting one. So let me come on the necrosis. So what is necrosis? Necrosis is the death of the cell. Of course, it is a cell death in a living tissue. It's not suicide. Here, it is along with inflammation. Apoptosis was with absence of inflammation, it is with presence of inflammation. In apoptosis, it occurs of single cell, but here it occurs of a group of cell. In apoptosis, no inflammation. Here, inflammation always present. So that is the difference between them. Now, here the types of necrosis are important. There are 5 types of necrosis. Are you aware of it? The 5 types of necrosis: coagulative, liquefactive or collicative, caseous, fat, and fibrinoid. Triple C, double F. The 5 types of necrosis. This one, collicative or liquefactive, one and the same thing. Give me a thumbs up. The 5 types of necrosis. Now, in your exam, the MCQs basically comes on their definition. I can guarantee how many students are attending live now. Even 10% of you or 1% do not know the difference between the definition, the 5 types of necrosis. You may be knowing, yes, all necrosis is cell death. They all are cell death with inflammation. With inflammation. Of course, they are with inflammation. It is a type of cell death. It is like murder. But what is the basic difference between coagulative, liquefactive, caseous? Do you know that? Right. So you should know the definition of each of them. Number 1. Number 2, you should know two causes. The specific two causes of each of them. Many MCQs come on the causes. Gross is not at all important for your exam, so you can skip it. But microscopy is important for image-based question. Nowadays, image-based questions are very common, especially in FMGE. You have your 25 to 30% paper is relatively image-based. So all the important images, the spotters, you must be aware and you should be able to identify it, right? So that's why microscopy is important. I know you are not a university exam aspirant, you have to draw the diagram, I know, but you have to identify in the image, na? So I will explain you microscopy also. Let me teach you the 5 types of necrosis. Before teaching you the 5 types of necrosis, I must give you a general detail. There is a cell. You all can see a beautiful cell. Cell have 3 details inside that. The outline of the cell. The outline of the cell is known as architecture. It's known as architectural detail, right? The outline. The cytoplasm. Now, cytoplasm color, cytoplasm granules present or absent, cytoplasm consistency, abundance, its amount. That is known as cytoplasmic detail, right? And the third thing is the nucleus. What is the color of the nucleus? Nucleoli present, absent, जो भी है nucleus के बारे में सब कुछ, it's nuclear detail. So based on these 3 details, I can identify the various cells of human body. You can see the human body have multiple cells, multiple type of cells. You can see they all have different shape, they have different outline, they have different cytoplasm, they have different nucleus. So basically on 3 details: architecture, that is outline and shape. Number 2, cytoplasmic detail, and number 3, nuclear detail. Based on that, I can identify the various type of cells. If you give me 3 details, ma'am, there is a cell, the cell is spindle shaped, the cytoplasm is red, the nucleus is blue, I can say, I think you are talking about a skeletal muscle cell, right? Likewise, if you give me the 3 details, now I can identify that cell. Or if you show me the diagram, right? If you understood this, let me start the necrosis. Have you got it? The 3 type of details. The first necrosis is coagulative necrosis, the most common among the 5. Among the 5, the most common is this one. See, what is the problem here? See, so this is a group of alive cell. Ye zinda hai cell. They are alive. They are alive. You can see the 3 detail. You can see its outline. You can see its cytoplasm. You can see its nucleus, right? In coagulative necrosis, the thing, what is the problem here? Architecture still persists. The outline, I can see the exact same outline. Exact same outline. It is not a problem. But cytoplasmic details are lost and nuclear details are lost. I can see cytoplasm pura badal gaya. I cannot identify. And nucleus is also either it is absent or it is destroyed or it is fragmented or it is pycnotic. So nucleus and cytoplasm changes are there. But architecture still present. Architecture means outline. Outline is still present. Give me a thumbs up. Everyone give me a thumbs up. Jitne audience. So what is the definition of coagulative? Architectural outline still persists, but cytoplasmic and nuclear details are lost. Right? So out of the 3 details, 1 is still presenting, but other 2 are lost. Architectural details persist, but cytoplasmic and nuclear details are lost. You got my point? So have you ever seen a ghost? Ghost मतलब भूत. देखा है कभी? मैंने तो नहीं देखा. I have not seen. Have you seen it? So the people say the ghost have only outline. The ghosts do not have inner details. So can I compare this cell with a ghost? Ghosts also have only outline, no cytoplasm, no nucleus, no organs, I mean. So only outline. So that's why the cells in coagulative necrosis are known as ghost cells. This is the reason. You must know the reason for everything. Ghost cell क्यों बोलते हैं भाई? Why we called them a ghost cell? What is the similarity between this cell and a ghost? Is there a similarity? Yes. The similarity is only outline. They have only outline. They don't have inner details. Number 2, have you seen a tombstone? Tombstone is a stone which is kept over the grave. It is a stone. So stone also have a outline. They don't have inner detail. So either call them ghost cell or call them tombstone cell. So both are same. We call these 2 words to coagulative necrosis. So in coagulative necrosis, we call the cell either the ghost cell or the tombstone appearance. Give me a thumbs up. You got it? So ghost cell or tombstone, these 2 are your PYQs. your MCQs, they are seen in coagulative necrosis. Say yes, you got it. Now, what are the causes? What are the causes? There are three causes of coagulative necrosis. I'm teaching you coagulative necrosis. The three causes of coagulative necrosis. Number one, ischemia. Human body from head to toe, we are made up of organs. All organs receive pure blood from the heart, from the aorta. They receive pure blood. Imagine if any of the organ do not receive blood. What will happen? Ischemia. And because of ischemia, the death of the cell of that organ. So death occurs due to coagulative necrosis in ischemia. If any organ do not receive blood, the death of that cell of that organ occurs due to coagulative necrosis except brain. If any organ not getting blood, the death occurs due to coagulative necrosis. But if brain is not getting blood, the death occurs due to liquefactive necrosis. You got my point? So पूरे organs एक तरफ और brain एक तरफ. So on one side liver, kidney, spleen, lymph node, muscle, all the organs, bones, all the organs. But on another side it's brain, right? If all these organs do not get blood, they will die because of coagulative necrosis. But if brain do not get blood, it will die because of liquefactive necrosis. Brain is an exception, don't forget. Very important MCQ. Yes, liquefactive necrosis or colligative necrosis. Say yes. Say yes. So learn the exception. Don't miss it. It's very important MCQ. Number one. Number two, burns. If you cook anything sometime, you can have burn on your hand, finger. Anywhere burn can happen due to accidental injury, right? So in the burn, that particular area, the cells of that particular area are dead, of course, because of the thermal injury. So that death is also coagulative necrosis. Thermal injury or burns, right? It can be minor burn, major burn. Right. Number three, Zanker's degeneration. It is a type of degeneration which occurs in muscle. It is also an example of coagulative. So learn three examples of coagulative. They are in front of you. We are done. We are done. Grossly, you can see the organ is pale, yellowish. That is coagulative necrosis. Gross is not important. Microscopically, you should be able to identify it. Can you see the two kidneys? This is normal kidney. This is a normal kidney, normal glomerulus and normal tubules. And this is coagulative necrotic kidney. The same kidney, the same kidney. The only difference, I can see the outline of the cells here, the same outline of the cell here. I can see the same outline. But see, the cytoplasm color is different, the nucleus is different. Only architectural detail persists. Nuclear and cytoplasmic detail do not persist. That is, these all cells are ghost cell or tombstone cells. That I have already taught you. And at the junction, appreciate the inflammation. Inflammation is present at the junction. Say yes. Say yes. Inflammation is always present. Without inflammation, you cannot say necrosis. It will convert into apoptosis. Inflammation must present to document necrosis. So we are done with coagulative necrosis. Here, architectural detail persists, but cytoplasmic and nuclear details are lost. Causes, I told you three causes. Ischemia of all organs except brain. Burns and Zanker's degeneration. Gross not important. Microscopy, tombstone appearance. That's it. We are done. Yes. MI will be a cause here. One of the cause, ischemia of all organ including heart. In MI, the ischemia of the heart is occurring, na? So yes, Vivek, you are absolutely right. Ischemia of all organs including heart also, but not brain. Not brain. So coming on the second one, liquefactive necrosis. So what is the definition? Here all three details are lost. Compare the two. Compare the two. Come on, everyone here. Everyone. See a group of live cell, group of live cell. Here, you can see the architectural detail persists, but cytoplasmic and nuclear details are lost. So, of course, it's coagulative necrosis. We have understood that. But here, I cannot see either outline. या तो outline तक नहीं दिख रही. Na cytoplasm, na nucleus, or I cannot see even outline. So, here all three details are lost. So, architecture is also lost. Cytoplasm is also lost. Nucleus is also lost. All three details are lost. Oh my God. What I can see then? A group of cell converted into a gel-like material. A semi-liquid like material, a gel. That's why it's known as liquefactive. It's like liquid. That's why known as liquefactive, right? So you can see the difference between coagulative and liquefactive necrosis. Now you can understand. So in coagulative, at least architecture persists. Other two details are lost. But in liquefactive, all three details are lost. So that's why we use the term tombstone and ghost cell for coagulative. But we don't use these terms for liquefactive. Here we use liquid, gel-like material. Give me a thumbs up. So these are the small details, finest details you must know. You must know. So that is the definition. Here, architectural, cytoplasmic, nuclear, all three details are lost. And ultimately, a group of cells get converted into a semi-fluid-like material, liquid-like material, gel-like material. Causes, one cause you already know, the exception there. Ischemia of brain. Ischemia of brain is coming here because that was the exception there. One of the reason you already know that, I guess. And the second reason is the pyogenic infection. Pyogenic means pus. To make you understand that it is occurring in the brain. It is due to ischemia of the brain. Yes, am I live now? You can see me, I guess. Okay, so it is a gel-like material, right? Grossly. And microscopically, you can see this. This is a healthy brain, normal brain this side, normal brain having neurons. And this is the liquefactive necrotic brain. Liquefactive necrotic brain. See, here I can see the neuron. I can see the three things. Outline also, cytoplasm also, nucleus also. These are healthy cells, neurons in the brain. Oh, they are beautiful. But what about here? Compare it here. I cannot see anything. I cannot see even a single cell. The outline is lost, cytoplasm is lost, nucleus is lost. What I can see only is gel-like material. This is, I'm sorry, this is all gel-like material. Gel-like material. So this is liquefactive necrosis. At the junction, inflammation is there. Give me a thumbs up. Have you got it? Can we go ahead? Right? So we are done with coagulative, liquefactive. Coming on the third one, caseous necrosis. Coming on the third one, caseous necrosis. Are you people there? Can we go ahead? Caseous. What do you mean by the term caseous? Caseous is a Greek word. It means cheese. You love cheese? I love cheese. Right? So cheese is, I guess it's very delicious to eat. So cheese. The cheese is the caseous. The word, Greek word is cheese. So caseous necrosis is cheese-like, looking like cheese. That's why known as cheese. How does the cheese look? Have you ever seen cheese? This one is cheese, I guess. Everyone have seen that. Cheese is dry, number one. Number two, granular. Granular. It's dot, dot, dot granular. And number three, it's homogeneous. Homogeneously white or yellowish type. So dry, granular, homogeneous, white or yellowish. So the necrosis also looks like that. Can you see this is lung? This is tuberculosis inside the lung. It is looking like cheese. Yes, it's looking the same way, dry. So let me mark the word dry, granular, and it's yellowish. So the properties of a cheese are here. That's why it's known as caseous. That's why it's known as caseous. Okay, compare the three. A group of alive, a group of alive, a group of alive. Here architecture was maintained, but cytoplasmic and nuclear details are lost. That's why it's coagulative necrosis. We can see in the diagram also. Here all three details were lost. Architecture also, cytoplasm also, nucleus also. But here in caseous also all three details are lost. You will ask me, ma'am, then what is the difference between these two? You will ask me, of course, between liquefactive and caseous. You are saying here also all three details are lost. Here also all three details are lost. Yes. Here all three details are lost and ultimately it got converted into a liquid material, semi-liquid gel-like. And here all three details are lost and it converted into a granular material, not liquid, a granular debris-like material. Can you see here it's liquid and here also it's like debris, dot, dot, dot granular debris. So that is the difference. That is the difference. You got it? So causes, there are two bacteria and two fungus, the causes of the caseous necrosis. The two bacterial infection is TB and syphilis. TB and syphilis, right? And the two fungus are histoplasma and coccidiomycosis. So only four causes. You have to learn the four causes. Microscopy, you know how a granuloma is formed. Here granuloma will be formed. You can see, okay, this side healthy lymph node. I can see the cells, the lymphocytes, their cytoplasm, nucleus, everything. And this side, I cannot see anything, not even single cell. I can see only debris, right? At the junction, inflammation is there, right? So we are done with caseous also. Coming on the fat necrosis. What do you mean by fat? What do you mean by fat? Can you tell me in human body, three fat-rich locations? Fat-rich, abundant fat-rich location in human body. Number one is female breast, not the male breast. Female breast, number one, of course, having abundant breast, abundant fat. Number two, pancreas. Pancreas of humans have abundant fat. And number three, mesentery or omentum. Very good. Mesentery or omentum, one and the same thing, having abundant fat. So if death of these three cells occurs, in these three organs, if death of cells occurs, it is known as fat necrosis. It is a special type of necrosis. Fat means death of adipose cell. These organs have adipose cells inside them. Adipose cells are the fat cells. So when death of adipose cells occurs, it's known as fat necrosis. And adipose cells present in three organs of human body, the female breast, the pancreas, and mesentery or omentum. Right? Yes. So fat necrosis is fat-rich location. You know the three fat-rich location. So death occurs over here. Yes. It looks chalky white in appearance. Can you see the word chalky white? It is due to saponification. Yes. And microscopically, we'll learn the word cloudy. Cloudy. It's look cloudy. Can you see? बादल के जैसा लग रहा है. Cloudy. Right? No architecture, no cytoplasm, no nucleus. It's look cloudy. Cloudy appearance. So we are done with fat also. And the last one is fibrinoid. Fibrinoid occurs in blood vessel, the wall of the blood vessel. You know the wall of the blood vessel have three layers, intima, media, and externa. Can you see here? This is the lumen of a blood vessel having blood. This is lumen. This is intima. This is complete media. Externa is not shown here. So in the media a ribbon, a pink color ribbon is formed. Can you appreciate this pink color ribbon? Pink color ribbon. This pink color ribbon is fibrinoid necrosis. So it occurs like a ribbon in the wall of the blood vessel, right? So in the wall of the blood vessel, it is basically occurring, and the reason is vasculitis. Due to the vasculitis of the wall, it is happening. That's it. That's it. So we are done. This is the master table. This is the summary table. Yes, definitely. Irfan, absolutely right. It occurs in malignant hypertension also. So this is the summary table. You cannot miss that. See the definition. See the definition here, here, here. I'm not reading again. Beautifully, I have summarized. Here it occurs at fat-rich location. You know the 3 fat-rich location. This one occurs in blood vessels. See the definition of all. See the causes of all. Here ischemia of all organ except brain. Here ischemia of brain. Here 2 bacteria, 2 fungus. Right, here the 3 organs you already know. Here vasculitis and malignant hypertension you can say. See the microscopy of all of them. Right, so everyone give me a thumbs up. I tried hard in explaining you the necrosis. Now any question based on necrosis you can do. If you can do, why don't you solve it here? So let me see who have understood it and attended the lecture attentively. Let me see. Let me see. So it is your test now. I want to see who is first and who is correct. First and correct both. Right. So this is the first question in front of you. Necrosis with cell body retained as ghost cell. Seen in which type of necrosis? What is the correct answer? So yes. So yes. So Meet Borda, you are absolutely right and first to answer, and everyone else is also right. Very good. So the correct answer is coagulated necrosis. I'm changing the question. Instead of ghost cell, I'm asking you tombstone. Tombstone cells. What is your answer now? What is your answer now? Would you like to change the answer? No, I don't think so. Still the answer is coagulated necrosis. Still the answer is coagulated necrosis. I'm changing the question again. Instead of this, I'm asking cheese-like material. What is your answer now? What is your answer now? Cheese-like material. Now what is the answer? Cheese-like mein kya answer hai? Let me see who is giving. Yes. So in that case, you will go with C. Who is there? The first to answer, Axomia doctor. Yes. So cheese-like is the, of course, it's caseous. Caseous is cheese-like. And if I change again, it's gel-like. What is your answer now? What is your answer now? Who will give the correct answer now? So I guess everyone knows the correct answer here is not liquefactive, the gel-like, right? So I'm not confusing you. So you can answer anything if you know the concept. That is my point. It is not the thing every year question will be asked on ghost cell. Maybe this year question is on cheese-like. Maybe this year question is on gel-like. Maybe question on tombstone. Anything can be asked. But if you know the concept, you can answer it correctly. Say yes. Can we go ahead? Okay, just a second. Okay. Yes. So correct answer here is coagulative necrosis. Coming on the next question. All of the following organs likely to undergo coagulative necrosis except. Don't miss the word except. So all of the organs have coagulative necrosis except. Yes. You all are right. The correct answer here is brain. Brain do not show coagulative necrosis. And ischemia of all other organs have coagulative necrosis. I cannot read who is the first one because all of you are right. And together you all are right. Very good. The correct answer here is D. The correct answer here is D. So liquefactive necrosis occurs in which organ? I've told you the causes of liquefactive necrosis. Is it heart, brain, lungs or spleen? The same question I'm asking in another way. The same question. Yes, yes. So again, the answer is B. So coagulative necrosis ka exception and liquefactive necrosis ka reason. The answer is same, brain. Last answer was also brain. That was an exception of coagulative necrosis. And this answer is also brain. It is an example of liquefactive necrosis. Please learn it. The correct answer here is brain. Without any confusion, it's brain. It's brain. So let me come on the next topic, a small topic, gangrene. What is gangrene? Can you tell me what is gangrene? Gangrene is necrosis plus putrefaction. It's already necrosis have occurred. But putrefaction ko Hindi mein kehte hain sadna. You know, whenever there is a dead cell, so bacteria get attracted and bacteria start putrefying the dead tissue. So that is known as putrefaction. You know, dead bodies सड़ने लग जाती हैं वैसा ही. So necrosis plus. So can I say gangrene is equal to N plus P? Necrosis plus putrefaction, over-added putrefaction. Gangrene are of 3 types: dry, wet, and the third type is the gas gangrene, which is the special type of wet gangrene. So I would like to tell you the differences between the two. Right, dry and wet. See, dry gangrene occurs. This is dry. Dry. Dry gangrene occurs in extremities, the foot, the fingers, the extremities, the digits, the extremities. Usually it occurs in extremities. The wet gangrene, this one is wet. The wet gangrene occurs in moist organs, like in intestine, like in vagina of the female, right? Like in the lungs, it's in the moist organ. So first see, it's in limbs, this one, and this one occurs usually in bowel. I've shown you the diagram also. This one is dry, this one is wet. This occurs in limb, this occurs in bowel. The dry occurs due to artery occlusion. The blood, pure blood is not coming. And wet occurs due to blockage of both artery and vein. Artery and vein. In the dry, the organ is shrunken and black. In the wet also, the organ is rotten and black. Here also organ become black. Let me show you. Can you see the black organ? Here also the intestine converted black. So black color is common in both of them, right? Here, less bacteria are there in dry. That's why less putrefaction. But here abundant bacteria are present. So abundant putrefaction, right? In the dry and the wet, right? You have to understand, like, less bacteria, less putrefaction. Abundant bacteria, abundant putrefaction. Now, line of demarcation. What do you mean by line of demarcation? Here, I can make a clear line between the viable and the dead tissue. This is a clear line. This is dead tissue, remaining is viable. I can make the line in dry. But in wet, where I should draw the line? I cannot make a line, that exact line between the dry, between the viable and the dead tissue. So here line of demarcation present, here it's absent, right? Prognosis is better here because less putrefaction, here it's poor. So yes, so okay. Fournier gangrene is an example of dry gangrene, and diabetic gangrene is an example of wet gangrene. You have to learn the examples also. That's all about gangrene. The third type of gangrene is the gas gangrene. It is due to gas forming bacteria. Can you name gas forming bacteria? Can you name gas forming bacteria? Clostridium. Clostridium is one of the bacteria which form gas. Now imagine this is a person. He was driving a motorcycle, and he got accident on the road, unfortunately. So he fall in the soil, and he is having injury over the thigh. He's having injury. So in the soil, there were spores of the Clostridium that get injected into the wound of this person. Now, after going inside, the spores get sporulation, and the bacteria is formed. The bacteria will form gas. So can you see the gas-filled bubbles in the wound? Can you see the gas-filled typical bubbles? Now, this is gas gangrene, the most dangerous one, the having worst prognosis. So here gas is present inside the wound because the gas is formed by the gas-forming bacteria. The name of the bacteria is Clostridium velici. Yes. So we are done with that also. I guess we are done with gangrene also. Give me a minute. So all the important topics of the first chapter are done here. Do you have any doubt or confusion here? Shall I move to the next topic? Inflammation. Shall I move to the next topic? Acute and chronic inflammation. Are you people still there? Can we go ahead? Okay. Let me come on the inflammation. What do you mean by inflammation? Inflammation is a defense mechanism of human body. Of course, we know defense, pigmentation is still there, Irfan, but I cannot cover all the topics here now. If I teach you all the topics in pathology, I require 2 to 3 days to cover entire pathology. But unfortunately, I'm having only one day. Today, I have to teach you the most important topics which are repeatedly asked in your exam. Right. But after that, if the team allows me, of course, I will take sessions on your exact PYQs. So I have picked up the last 5-year PYQs, and if the team allows, but definitely we can consider, we can take the 5-year PYQs of pathology in one session, in one day, all PYQs, right? So whatever question will be coming, we will be discussing that. So in that, I guess pigmentation or other topics will be covered. So yes, I'm coming on the inflammation, the acute and chronic, both I will cover in short. So inflammation is the defense mechanism. We know it is a human defense mechanism. There are 2 types of inflammation, the acute and the chronic. Do you know the difference between them? See the 2 diagram. Acute inflammation, the best example is tonsillitis. Do you have tonsillitis sometime in your life? Yes, I have multiple times. It's very common. Chronic inflammation, the best example is TB. Right, the best example is TB. Now let me tell you, here onset is fast, here onset is slow. Right, here as soon as the bacteria, the streptococcus bacteria enters, it causes tonsillitis. But here the bacteria is Mycobacterium tuberculosis, it enters, remain there for years, and when the immunity drops, then it causes infection. That's why here onset is fast, here onset is slow. Right, here duration is also less. If I have tonsillitis, maximum it will be for a week. After 1 week, it will be subsided, whether I take treatment or do not take treatment. So maximum it is for a week. But if someone have TB, it will be for 6 months. If the person take treatment, and if the person don't take treatment, it will be for 2 years. So here duration is less, duration is more. Onset is less, onset is fast and slow, right? The third thing here, most important cells in acute inflammation is neutrophil. And in chronic inflammation, the most important cells are monocytes. Both are WBCs. WBCs are of 5 types now. Here neutrophil is the most important cell, here monocyte is the most important cell, right? What is the hallmark feature in acute inflammation? In acute inflammation, the hallmark feature is edema. Edema is always present in acute inflammation. In chronic, edema is never present. In chronic inflammation, the hallmark is the granuloma. Granuloma will occur. Granuloma. Give me a thumbs up. Come on. Give me a thumbs up. You got it? The differences between acute and chronic. In acute inflammation, the onset is rapid. In chronic, the onset is slow. In acute inflammation, the duration is short. In chronic inflammation, the duration is longer. In acute inflammation, the hallmark is edema. In chronic inflammation, the hallmark is granuloma. In acute inflammation, the most important cells are neutrophils. But in chronic inflammation, the most important cells are macrophages. Can we go ahead? Yes. The two types. Let me start acute inflammation. Let me tell you the 5 events of acute, okay, before coming on the vascular and cellular events, let me teach you the cardinal signs in acute inflammation. Do you know what are the main cardinal signs? What do you mean by cardinal signs? Cardinal signs are the signs which are present in each and every acute inflammation. We can have acute inflammation from head to toe in any organ. In the brain, we can have meningitis. In the brain, we can have encephalitis. We have endophthalmitis. We have rhinitis. We have tonsillitis. We have bronchitis. So as you move ahead, in all the organ, we can have acute inflammation in each and every organ technically. None of the organ is spared. We can have acute inflammation in all the organs, of course, right? So head to toe, we can have everywhere. So these are the 5 signs which are present in acute inflammation everywhere, all the organs. So imagine the best example is tonsillitis. Acute से मुझे tonsillitis से याद आता है. Easy to remember, ना? We have experienced it. So whenever I have tonsillitis, my tonsil become red. Yes, your tonsil also become red, I guess, during tonsillitis. So during tonsillitis, the organ become red, right? So temperature of the tonsil is more as compared to surrounding temperature. Right, the temperature is more. Number 3, the tonsil swelled up. You can see the swelled tonsil. The tonsil becomes swelled up. There is pain in the tonsil. Whenever we have tonsillitis, we have pain, right? And there is temporary loss of function, not permanent. Temporary loss of function of that organ. These are the 5 signs. The organ turn red, not only tonsil. Any organ having acute inflammation have the 5 signs. These are the cardinal signs of acute inflammation. What are the 5 cardinal signs? Number 1, the organ turn red. Number 2, the organ swells. Number 3, the temperature of that organ is particularly more as compared to the surrounding temperature. Number 4, the organ will have pain. And number 5, there is temporary loss of function of that organ, right? I have said this in English language. I know only 2-3 languages, right? So that's in English language, but the examiner want you to learn in Latin. Do you know Latin? I don't know Latin. So we have to learn the English language into Latin. We have to convert. So redness in Latin is known as rubor. Your MCQs come in Latin language. I don't know why. From this topic, not in complete pathology. Complete pathology hota to pura Latin padna padta. But only the cardinal signs you have to learn in Latin language, right? So redness in Latin is known as rubor, right? Increased temperature is known as calor. Have you heard the instrument calorimeter? Calorimeter is an instrument which measures temperature. So calor se aaya hai calorimeter. You can learn like that. Swelling se aaya tumor. English mein tumor means neoplasia, but in Latin tumor means swelling. In Latin, I'm saying tumor. I'm not saying tumor in English. In tumor, English, it's neoplasia. But here, it's swelling. Pain is dolor. Pain is dolor. And loss of function is functiolacia. So can you tell me the 5 cardinal signs in Latin language? Rubor, calor, dolor. What was the 4th one? Functiolacia. I'm forgetting one. Redness, increased temperature, increased pain. What was the next one? Tumor, swelling. I forgot that. Okay. So rubor, calor, dolor, tumor, and functiolacia. So these are the 5 in Latin language you have to learn. You get many MCQs or PYQs on this. It's a simple thing you have to learn. Now let me start the events of the acute inflammation. Can we go? Can I start? The acute inflammation, the 2 type of events of the acute inflammation. There are 5 vascular and 6 cellular events. So total 11 events I'm going to teach you. You get multiple MCQs from these 11 events, right? So you must know the 11 events of acute inflammation. How does it occur? How does it occur? The 5 vascular and 6 cellular. So these are the 5 vascular. I'm not reading. I will directly explain you. These are the 5 vascular. These are the 6 cellular, right? So you can see these 5. I will explain you. These are the 6. Total 11 events I'm going to explain you in this diagram. This is going to be the master diagram in which I will explain all 11 events at one glance. No one other than me in this world can teach you with this simplicity. See, I'm teaching you. Listen. All 11 events I will teach you here. What is this diagram? Imagine this is the skin, the yellow color. This is the skin. Imagine this is my hand. This is the skin of my hand. You can see the yellow color. Just below the skin, this is the blood vessel. We all have blood vessel everywhere now. So below my skin, here also I'm having a blood vessel. So this is the blood vessel. Can you see this one, the red one? All the blood vessels are lined by endothelial cells. So I guess everyone knows these are the endothelial cells, the red color cells, right? The red color cells. Now, inside the blood vessel, we have RBCs, we have platelets, and we have WBCs. Currently, I'm interested in WBC. That is our army. the defense army, right? So every country have the army now. So the body is like a country and the army of this country is the WBC. So I'm drawing only WBC. I'm not drawing RBC and platelets. I'm interested in WBC. So these are the green cells. These are the WBCs present inside the lumen of the blood vessel. Say yes, right? Now there is a terrorist. The terrorist is this purple color and this is the bacteria. Imagine the terrorist is the bacteria coming. This is a foreign particle coming from outside. So anything coming from the foreign for a country, not every foreign, but yeah, it is a terrorist. So that is a, so as soon as the terrorist entering in a country, what happens? The army is activated. The army is activated and army wants to kill the terrorist, fight with the terrorist and kill the terrorist, obviously. So here the bacteria is the terrorist and the green color WBCs is the army. We want to make a fight between them. If the bacteria wins, the person have infection. And if the WBC wins, the person have inflammation. You want what? You want infection or inflammation? So if you have good immunity, you will have inflammation. But if you have bad immunity, immunity is poor, the person can have infection. So who is winning in the fight? The bacteria is winning or WBC is winning? The terrorist is winning or army is winning? So based on that, the person can have infection or inflammation. Say yes, say yes. But the most important thing for deciding who is winning, we have to make them fight. To make them fight, they should meet. They should meet with each other so that they can fight with each other. Now there is a problem. One is extravascular, one is intravascular. You can see here the bacteria is extravascular outside the blood vessel and the army is intravascular. Now to make them fight, you have to meet them. Now there are two possibilities, either take the bacteria inside. No, it's a bad option. If you take the bacteria inside, it will spread in all organs, the person will have sepsis. No, we cannot do that. We cannot afford sepsis in all organs, right? So we cannot do that. No, not a good idea. What the other way around? Take the WBC out. Yes, looks better. So we will take the WBC out. So basically the 11 events I'm talking about now, these all events occur to take the WBC out. We want to take the it cannot go directly in one step. Oh, go the WBC out. It will go step by step. So it will take 11 steps to take this WBC out and make a fight between them. So that is the 11 steps. That is the 11 steps of this thing, acute inflammation. So you got my point. So why I'm going to teach you 11 steps? Ultimately, I want to take this WBC out and make a fight between the bacteria and the WBC. Shall I start the 11 steps? If you give me permission, if you give me thumbs up, then only I will go ahead. Have you got the basic? Can we go ahead? Say yes. Can we go ahead? Okay. So the first step, I'm starting with vascular events. I'm starting with vascular. The 5 vascular first I will let you know. So the first is transient vasoconstriction. Listen, as soon as the terrorist is coming now, this is the terrorist. As soon as the terrorist, the bacteria is coming, the blood vessel got afraid. Oh my God, who is this? So that portion of the blood vessel undergo vasoconstriction. Can you see? But it is very transient. It is very transient. It is for a fraction of second. For 1-2 seconds only. That's it. So the first step is transient vasoconstriction. It is vasoconstriction, I agree. Not the complete blood vessel. Only that portion of the blood vessel undergo vasoconstriction. But it is transient. So it is the first step. It is the first step, the transient vasoconstriction. The second step is this one, vasodilatation. After vasoconstriction, that portion undergo vasodilatation. Pehle vasoconstriction hua. And now the same portion undergo vasodilatation. But this is not transient. This is persistent. Ye ab aisa hi rahega for many hours or days. It is persistent till healing occurs. It is persistent, right? So first step was transient vasoconstriction. The second step is persistent vasodilatation. Now because of the persistent vasodilatation in this portion, more blood will come here. Agree or don't agree? More blood will come here, na? More blood. So if you are looking from above, this is your eye. This is my eye. I'm looking at this portion. I'm having inflammation here. So there is more blood in this fragment. Because the blood vessel below this portion of the skin, it is dilated. So more blood, so this portion will appear red to me. If I look from above, this portion will appear red to me. You got my point? This portion will appear red and this portion will appear, if I touch it, it will be warm. Warmer than the surrounding because of more blood. So out of the 5 cardinal signs, I have proven 2. Rubor and calor. It is due to the vasodilatation. Rubor and calor. Redness and warmness. Say yes. You got it? So because of this, there is redness and warmth I can prove because of the vasodilatation. I will prove all 5. The first 2 are proven, right? Now the third step, because there is more blood in this portion. In this portion, you can see there is more blood. More blood means more water. What is blood? 90% of the blood is water. More blood means more water. Because of the more water, there is more hydrostatic pressure. There are 2 types of pressure. Hydrostatic is outward, oncotic is inward. So outward pressure is increased. So fluid, यहाँ पे ज़्यादा blood है ना? So extra fluid will go out. All the extra fluid will go out and accumulate here. It will accumulate here. It is known as edema. Edema. And edema will give to tumor, the swelling. If you touch here, you will feel there is a swelling. If you see from above, there is a swelling. That is tumor. Tumor is due to increased hydrostatic pressure. So what are the 3 steps till now I told you? I'm going to teach you 5 steps of vascular events. The first is the vasoconstriction, which is transient. The second is the vasodilatation, which is persistent. And third is increased hydrostatic pressure. Say yes. Due to vasoconstriction, nothing important is there. Vasodilatation leads to rubor and calor, and increased hydrostatic pressure leads to tumor. That is edema. Say yes. Shall I move to the next step, the fourth one? The fourth step here is increased vascular permeability. What do you mean by increased vascular permeability? You know, blood vessel is continuous. Let me draw a blood vessel. These are the endothelial cells. They are continuous with each other. There is no gap. There is no gap in between. But you say, ma'am, you said that this is WBC and you want to take WBC out. How you will take WBC out? There is no gap in the blood vessel. How you will take out? So I will say I will create gaps first. First I will create gaps and then I will ask the WBC to come out. Okay? So I'm creating gaps. Creating gaps in the wall of the blood vessel is known as increasing vascular permeability. I'm increasing the permeability of the wall by creating gaps in that. That it means. So increased vascular permeability, it is the most important step. Among all 11, this is the hallmark step. Because I am created. Can you see I have created gaps? Can you appreciate the gaps? So yes, this is a gap, this is a gap, this is a gap, this is a gap. So I have created gaps. That is, I have increased vascular permeability, and later on this WBC will come out. Currently WBC is not coming out. Later on I will take it out. Say yes, right? So this is creating gaps. And last one is stasis. Stasis of the blood. The blood will show here stasis. Right. So these are the 5 steps. What are the 5 steps? Who will enumerate the 5 steps to me? Please help me. So vasoconstriction, which is transient. Vasodilatation, which is persistent. Increased hydrostatic pressure. Increased vascular permeability, and stasis. These are the 5 vascular events, and now I will tell you 6 cellular. So acute inflammation will be over after this. Yes. So you know the relevance of each of these steps. You know the sequence, you know the relevance of each of them. We will solve some questions based on vascular events and then we will move to the cellular events. So the first question is in front of you, repeatedly asked in your exam. Repeatedly asked in your exam. Can you answer it? Can you help me in answering? Yes. Can you tell me the sequence of the events in the acute inflammation? I have told you the 5 events. Now please put them in a sequence. Please put them in a sequence. So everyone is saying D, someone is saying C. Is it C or D? Oh my God, C or D? Most of them are saying D. Someone is saying C also. I don't know why. Stasis is the last one. Now, why you are saying C? So D is the correct answer. So the first step is the transient vasoconstriction. The second is persistent vasodilatation. The third step is not given here. Increased hydrostatic pressure. It is missing. The fourth one is increased vascular permeability. And last one is stasis. This question is repeated multiple times in your exam. You can check your PYQs. Right? So you should know the sequence. The next question. Can you tell me which step is the first one among the following? Is it vasodilatation, vasoconstriction, increased vascular permeability, or decreased vascular permeability? Which is first occurring, first to occur? First to occur. Yes, so most of you are right. It's vasoconstriction. Although it's transient, I agree. But it happens now. You cannot miss it. So yes, so the first step is always vasoconstriction. Usually students miss this step because it is transient. They don't read from the books properly and they go with vasodilatation. No, vasodilatation is the second step. It's not first. Right. So this is the, I will go with B. I will go with B. Right. This is the next question in front of you. Can you tell me the reason for the rubor? Can you tell me what is the reason for the rubor in acute inflammation? What is rubor, by the way? What is rubor, by the way? Rubor is redness. So can you tell me the reason for the redness? I told you very clearly. Yes, redness occurs due to, redness occurs due to increased dilatation, vasodilatation. Vasodilatation means more blood. If I am having more blood in this fragment will appear red to me. You know, this fragment. Do you have mosquito bite, experienced mosquito bite in your life? Of course, we all have, right? I am having multiple mosquitoes nowadays at my home. So whenever we have mosquito bite, that area have redness. So it is a typical example of inflammation. All 5 things you can imagine in the mosquito bite. So there is redness, there is tumor, right? There is pain, there is elevation, and there is temporary loss of function of that particular area. So you can imagine the vasodilatation of that particular focal is due to vasodilatation. So the correct answer here is vasodilatation. Say yes. So correct answer here is A. You got my point? So rubor is due to increase vasodilatation of the artery. But if I change my question and I ask you vasodilatation, okay, it is not given here. Okay, let it be. So we are done with the 5 vascular events. 1, 2, 3, 4, 5. Let me come on the 6 cellular events. You will say, still WBC is not out now. My ultimate purpose is to take the WBC out and make a fight between the bacteria and the WBC, between the terrorist and the army. So I will fulfill that purpose in the next 6 events. So let me talk about the cellular events. But before coming on the cellular event, can you tell me the summary of the vascular event? Ab tak kya ho gaya hai? Ab tak ye ho gaya hai. Till now, this has already occurred in the vascular event. This is the summary of the vascular event. In the vascular event, we have already created a gap. We have already created a gap. The gap is present. Now in cellular event, we have to take WBC out of this gap. You will say, ma'am, for that you require 6 steps. Yes, I require 6 steps to take this WBC out. The gap is already present. In the vascular events, we have created it. We have created it. But we have not taken WBC yet out. Now, you will say, ma'am, why you require 6 steps to take just WBC out? What is the problem? The problem is the problem is the Bernoulli's theorem of physics. Have you read physics? Yes, I read physics, was one of my favorite subjects. So in physics, we have read a theorem, a Bernoulli's theorem. It is regarding a pipe, right? Whenever any fluid travels in a pipe, so the Bernoulli's theorem says that the heaviest portion of the fluid travels at the center. The heavy will travel at the center, and the lightest portion travels at the periphery. Have you heard this theorem? The lightest portion travels at the periphery. Say yes. Say yes, right? So among now blood vessel is also a pipe, now it is like a pipe. It is an empty pipe. Inside that we have RBC, WBC, platelet, and plasma. 4 things we are having. Which is the heaviest? WBC is the heaviest, unfortunately. So WBC travels at the center. WBC travels at the center. After that RBC ka coating. After that platelet ka coating, and lightest is the plasma, which is at the most periphery. Now the problem is that the WBC is at the center. The WBC is at the center because of Bernoulli's theorem. But the gap is at the periphery. The gap at the periphery. If WBC was already at the periphery, it was easy to take it out. Like first from the center, I have to take it to the periphery. And then from the periphery, I have to take it out. That's why I require 6 steps. You got my point? So the usual blood flow in which WBC is at the center, it is known as axial blood flow. What it is known as? I'm having axial blood flow. You are having, we all have axial blood flow, right? But I have to make reverse axial blood flow, in which I have to take the WBC from the center to the periphery first and then take it out. Give me a thumbs up. You got it? Say yes. So everything is very easy if you understand. So these are the 6 cellular events. Let me show you in a diagram. So see, this is the WBC. Everyone here, everyone on the screen. This is the WBC at the center. See, first I am taking the WBC from the center to the periphery. It is known as margination. The first step, I'm taking it to the margin. It is known as margination. I'm taking it to the margin. Now here is my gap. My gap is here. So I have to take the WBC from here till here. So the WBC will roll. The second step is rolling. The WBC will roll like a tire on a road. Like a tire on a road. So the second step is rolling. Right? The second step is rolling. Just before the gap, it will stop. It will stop rolling. So the third step is adhesion. So first is margination, then rolling, then adhesion. After that, the most important step, WBC will come out. WBC will come out for fighting with the bacteria. So that step is known as either transmigration or diapediasis. Diapediasis, one and the same thing. Transmigration or diapediasis. Now WBC is already out in the 3-dimensional space. In the 3D space. Now WBC don't have eyes. Where is the bacteria? Where is the bacteria? I will go and fight. No, WBC cannot say. In the 3-dimensional space, where should the WBC move? So the bacteria, who is the terrorist, it will secrete certain chemicals from inside. And that chemicals will attract the bacteria. I am here. Come, I am here. Please come and fight with me. So this process is known as chemotaxis. Chemo, it is chemical gradient. Taxis means movement. So bacteria, where the bacteria move in the 3-dimensional space, from where it will get the chemical. The chemical is secreted by the bacteria. So the 5th step is the chemotaxis. And after reaching here, the WBC will do the phagocytosis of the bacteria. So last step is phagocytosis. Everyone give me a thumbs up. Can you enumerate the 6 steps? Close your eyes and imagine the 6 steps. Don't learn. Just close your eyes and imagine. The first step is the margination. WBC leave the center and come at the periphery, reverse axial blood flow. That is known as margination. After margination, it is rolling. After rolling, just before the gap, it is stopping. That is adhesion. After adhesion, it is coming out of the blood vessel. That is known as diapediasis or transmigration. After that, it is moving towards the bacteria because of the chemicals secreted by the bacteria. That is known as chemotaxis. And in the end, phagocytosis, the WBC is engulfing the bacteria. Right? So these are the 6 steps you must learn in a sequence. ठीक है, the same diagram from the Robbins, the latest diagram from the Robbins 10th edition. So recently I purchased the 10th edition of the Robbins and updated my notes according to that. So this is a diagram given here, the beautiful diagram showing the same sequence. You can see here there is WBC. It is coming towards the periphery, that is margination. Then it's rolling, rolling, rolling. Then it's adhesion. Then it's diapidiasis. Then it's moving towards the chemical chemotaxis. In the end, it's doing the phagocytosis. I can see the 6 steps. Opsonization is not there. Phagocytosis, you can say, opsonization is a type of phagocytosis only, you can say. So it will be a part of phagocytosis. You got my point. Now my question to all of you, I want to ask you a question here. Let me give me a chance to ask you a question. Out of the 6 steps, I am interested specifically in these two, rolling and adhesion. How does they happen? I'm saying that the WBC is rolling. It is rolling like a tire on a road. You will say, ma'am, how does it happen? WBC don't have eyes that I have to move round and round and round. How does it happen? How does? It happens because of the receptors. What I mean to say, there are complementary receptors. Can you see this is the road? The red color is the road. I mean the road is the endothelium. The road is the endothelium, right? And I mean the green color, these are the tires. These are the tires. The tires are the WBC. So there are receptors, the pairs of the, can you appreciate the pairs? So there are pairs of receptors present, they form bond between them. So one receptor on the road, one receptor on the tire, they correspond each other. They form a bond. Bonds are transient. They form, they break. They form and they break, WBC will move a little. Then again they form, they break. Then WBC move a little. In this way, rolling takes place. Say yes, say yes. So there are 5 pairs, or specifically to be specific, there are 6 pairs. There are 6 pairs. You have to learn the pairs. One is husband, one is wife. So they are pairs. You cannot cross match. One is there. You have to learn the pairs, the corresponding couples, the pairs, the 6 pairs, right? So these molecules which are present, one on the road, one on the tire, that is one on endothelium, one on WBC, these are known as complementary adhesion molecules. CAMs, complementary adhesion molecules are the pairs. So you have to learn 6 pairs on which many MCQs come. So first pair is the P-selectin and E-selectin. P and E-selectin present on the endothelium and they form bond with silyl-Lewis X. I will show you in the diagram also. You can imagine my hard work. I have drawn these diagrams by myself with this pen before taking this lecture so that I can save your time, right? To simplify the concept. So I'm taking lecture for 3 hours now. Before taking the lecture, I sit for 3 hours and make these diagrams for you. So it's actually a 6 hours effort for you. Anyways. So it's worth, if you understand, it's worthy. You can see the first pair. Can you see the first pair, the name of the first pair? On the first pair, C, on the endothelium, it's P-selectin and it's forming a bond with silyl-Lewis X. Again, see the second pair. On the endothelium, it's E-selectin. P and E-selectin present on the endothelium. And both of them form bonds with silyl-Lewis X, which is present on the tire. So you have to learn which is on the road, which is on the tire. You have to learn the corresponding pairs. Very easy in the diagram. The first 2 pairs are over. The third pair, the L-selectin is present on WBC. There are 3 selectins, understand? There are 3 selectins, C. P-selectin, E-selectin, L. L for leukocyte. Leukocyte is WBC. So you will not forget now. L-selectin present on WBC. The remaining 2 selectins are present on the road and L-selectin present on the tire. You got my point? So P and E-selectin form bonds with the silyl-Lewis X. Say yes. And L-selectin form bond with the glycam. Right. The next are ICAM, VCAM. They form bond with integrin, beta 2 and beta 1 integrin. So these are the 5 pairs which helps in rolling and adhesion. The last pair is same. Only one pair in which the same molecule is present on the road as well as tire. What is the name of that molecule? You can see the name of that molecule is PCAM. Very important MCQ, PCAM. It is present on the road also and this PCAM is present on the tire also. So same molecule present on both and it is forming bond with each other. Right. And this PCAM is important for transmigration, not for rolling, not for adhesion. It's important for diapidiasis. It's clearly visible in the diagram if you got it. It's very clearly visible. So please learn the 5 pairs, actually 6 pairs, and the last pair is responsible for diapidiasis. Everyone give me a thumbs up. Everyone. I can share the PDF with you if the team allows. Where to share? I don't know where to share. I can share with the ProCM team and you can ask the ProCM team persons and the team can share with you, right? Anyways, let's move ahead. I don't know where to share the PDF with you, but I definitely will give it to the ProCM team and you can ask them. Let's move ahead. So that was about PCAM. PCAM is responsible for diapidiasis and PCAM is the only molecule it is present on both. PCAM is equal to CD31. Say yes, right? So you can see clearly this is transmigration and it is due to PCAM. PCAM is present on the endothelium as well as on the WBC. Now next is chemotaxis. Chemotaxis is what? After coming out, the bacteria is secreting the chemical that is attracting the WBC, right? WBC don't have eyes, I have to go here. It is due to the chemical it is moving. So can you name the chemical? Can you name the chemical? There are 3 chemicals you have to learn here. The name of the 3 chemicals. The first is leukotriene B4. Learn it. Leukotriene B4. The third is C5A and C3A. Complement C5A and C3A. And last is interleukin 8. You will get confused in the numbers. You have to learn. So leukotriene, interleukin and complement. Can you tell me the numbers? Leukotriene is B4. Interleukin is 8. And complement is 3A and 5A. C3A and C5A. You have to learn the numbers. There is no skip. You have to. Strongest is C5A, repeated PYQ. Which among the following is the strongest? Most potent chemical. Strongest is C5A. Give me a thumbs up now on every point at least. You got it? If you got the concept, give me a thumbs up. Right. Last one is phagocytosis ultimately. We are done with that. So let me revise. Acute inflammation is over. The 5 vascular event and the 6 cellular event. Can you help me in revising? The 5 vascular and the 6 cellular. First revise 5 vascular. This is the master diagram. Show everything 11 events here to me. Can you show me? Yes, I can do so. So the first step is, see here, vasoconstriction, which is transient. The second step is vasodilatation, which is persistent. Say yes. The third step is increased hydrostatic pressure, which leads to edema. Right. The fourth step is increased vascular permeability, because of which the gaps are formed. And the fifth step is the stasis. Vascular events are over. Coming on 6 cellular events. In the 6 cellular events, the first is the margination, WBC leaving from the center to the periphery, then rolling, then adhesion, then diapediasis or transmigration, then chemotaxis, then phagocytosis. We know chemotaxis, the name of the chemicals, and the strongest is C5A. And for rolling and adhesion, we know the pairs, the couples, the 6 couples. Give me a thumbs up. I am done. I am done with acute inflammation. I guess we will be doing some questions based on that and move to the chronic inflammation. Right. So the first question is in front of you. Can you tell me the answer? Can you tell me the answer? Just a second. Can you tell me the answer? What is the correct answer here? Can you see the question? Can you tell me the correct sequence in the extravasation of the WBC? I'm asking about the cellular events. Is it margination followed by rolling, followed by adhesion, followed by transmigration? Yes. So A is the correct answer. You can see other matches are not proper. So you know the six events, and from that you have to match the sequence. So sequence ka question is very common from vascular events as well as cellular events, and you all are right. Keep it up. Keep it up. Very good. Correct answer is A. Very, very, very good. The correct answer is here. Can you tell me the next question? Most important for diapediasis. The most important receptor for diapediasis. I just now told you, no? The only receptor which is present on both, the only molecule present on both the rod and the tire. Of course, it's PCAM CD31. It's PCAM CD31. Yes, it's PCAM. Can you tell me the next question? All of the following is a family of selectin except. There are 3 types of selectins, not 4. So one of them is not a selectin. Can you tell me what is the correct answer? Yes. So A selectin, there is no selectin with this name. We have P selectin on the endothelium, E selectin on the endothelium, L selectin on the WBC. But there is no A selectin. A selectin is not selectin. So correct answer is C. That is A selectin. Right? So yes, you are right. Can you tell me the definition of chemotaxis? What is chemotaxis? Can you read the 4 options? What is the correct definition of chemotaxis? I told you. Chemotaxis kya hai? So chemotaxis is a unidirectional movement. It's unidirectional. The WBC will move in one direction towards the bacteria because of the chemical secreted by the bacteria. It's not random multidimensional movement. No, it's unidirectional because of the chemical. So correct answer here is B. What is the correct answer here? The correct answer here is B. You got my point? Can you tell me which among the following are chemotaxis, chemokines, the chemicals for the chemotaxis? I've told you the list of the 4 chemicals. So, can you tell me which among the following is correct? I told you the list. One of them is leukotriene, one of them is interleukin, and 2 of them are complements. So, leukotriene B4, interleukin 8, complement C3A and C5A. So, I guess if you match these 4, the best option to go with is B. In the B, we are getting leukotriene B4 and C5A. C5a. In the C, C4 is not chemokine. C3a, I agree, but C4 is not. Bradykinin is not, histamine is not, so best to go is B. So in the exam, you get confused. You got my point, so you have to learn it properly. So correct answer here is B. So all about acute inflammation is done, and I guess any question coming on the inflammation, you are ready to answer. Coming on the chronic inflammation now. In the chronic inflammation, it's a type 4 hypersensitivity in which granuloma is formed. So let me tell you the steps. How does a granuloma is formed? In the chronic inflammation, there are only 3 steps, not 11 steps. Very easy to understand. Only 3 steps. In acute inflammation, there were 11, but in chronic, only 3. It's a small, very small topic. So how does it happen? Right? So as soon as, let me show you all 3 events in this diagram. This is the antigen. As soon as the antigen enters human body, so the first cell is antigen presenting cell which engulf it. Can you see? The antigen is engulfed by antigen presenting cell. The antigen is inside the cell now. But this antigen cannot be degraded. It is non-degradable antigen. It is not degraded, it is not phagocytized. So ये antigen presenting cell क्या करेगा? ये confuse हो जाएगा कि अरे मैं तो उसको खा ही नहीं पा रहा. I cannot do phagocytosis of this antigen. It is non-degradable antigen. I cannot eat it. What should I do? So it will go to the T cell. T cell, that there is an antigen in our body. It is a foreign antigen. I'm trying to eat it, but I'm unable to eat so. Because it is non-degradable antigen, what should I do? So this T lymphocyte, it is helper Th1 lymphocyte. It will get activated. It will say, no problem. I will secrete 3 chemokines, 3 chemicals from me, 3 cytokines from me. The name of the 3 cytokines is TNF, interferon gamma, and interleukin. It will secrete 3 chemicals from it. The 3 chemicals bring 3 type of cells. The 3 chemicals are bringing the 3 type of cells. TNF is bringing the fibroblast. Interferon gamma is bringing the monocytes. Monocytes come out and convert into macrophage or epithelioid cells. And interleukin will bring more and more T cells. And ultimately, the accumulation of the 3 type of cells is granuloma. Let me show you the diagram of a granuloma. How does it form? So at the center of the granuloma, we have epithelioid cells. What are these epithelioid cells I am drawing? Epithelioid cells are actually monocytes which converted into macrophages, and these are epithelioid cells. They are surrounded by T lymphocytes. They are surrounded by T lymphocytes, and they are surrounded by fibroblast. So 3 type of cells form granuloma. The 3 type of cells are due to 3 type of chemicals I told you. So the epithelioid cells are due to interferon gamma, the most important chemical, which convert the monocyte and macrophage into epithelioid cells. The T lymphocytes are due to TNF, and the interferon, the fibroblasts are due to interleukins. So you have to learn the 3 type of chemicals. Ultimately, a granuloma is formed. The center of the granuloma may have a caseous necrosis at the center. That's all about a granuloma. Don't learn the steps. You understood it? Give me a thumbs up. So ultimately, a granuloma is formed like this. You can see the 3 type of cells I have enumerated. Right? The most important among them are the giant cells. Now, what do you mean by giant cells? What are the 3 type of cells formed granuloma? Can you tell me the story again? I guess you people are confused. Let me repeat it. Okay, this is the antigen, right? It is coming in human body. This is the antigen presenting cell engulfing the antigen. It will engulf the antigen. Now, the antigen presenting cell engulf the antigen but unable to degrade it. So it will take the antigen to next cell. What is the next cell here? Next cell here is Th1, helper Th1 lymphocyte. It will secrete 3 chemicals from it. What is the name of the 3 chemicals? Can you tell me? The most important is interferon gamma. The second is TNF. And the third is interleukin 1 and 2. Right? They will attract 3 type of cells from the blood. Interferon gamma convert monocyte into macrophage. Monocyte get converted into macrophage, and macrophage get converted into epithelioid cells. Epithelioid cells are modified macrophages. So this is the summary of interferon gamma, right? TNF will attract the fibroblast, right? And interleukin will attract the lymphocytes. Now we are having 3 type of cells in our hand: epithelioid cells, fibroblast, and lymphocytes. Because of the 3 chemical, they will gather. This will form the center, right? This will form the middle zone, right? And this will form the periphery. They will gather and they will form a granuloma. Give me a thumbs up first. Give me a thumbs up. Fatafat, give me a thumbs up. So can you help me in drawing the diagram? Are you people there, listening or sleeping? So can you tell me drawing the diagram of a granuloma? At the center, we have epithelioid cells. Say yes. Say yes. The middle zone is formed by the T lymphocytes. Say yes, the middle zone. And the outermost zone is formed by fibroblast. Say yes. The outermost zone is formed by this is a granuloma. Now, multiple epithelioid cells fuse with each other. They fuse with each other and they form giant cells. So what are giant cells? Giant cells is formed due to the fusion of the epithelioid cells. It is formed due to the fusion of epithelioid cells. So how many types of giant cells are there? It's very important MCQ. There are 4 types of giant cells. You can see the diagram. You can see the first type is the foreign body of giant cells. Giant cell is something which is having multiple nucleus inside that. Multiple nucleus, that is known as giant cell. So in foreign body, there is no particular pattern. The nucleus is present haphazard. The nucleus is present haphazard inside the cell. Haphazard anywhere in the cytoplasm, right? The second type is Langerhans. In the Langerhans, the nucleus is present either at the north and south pole, that is at the poles, not haphazard, it is accumulated at the poles, number 1. Or it is present at the periphery in the form of a two-third ring. Can you see? Two-third ring. It is known as horseshoe arrangement. In Langerhans, one of the two pattern is present, either horseshoe or polar. It is not haphazard. The third type is known as Taunton. The third type is known as Taunton. In the Taunton, the nucleus will form a ring. Multiple nucleus gathered together and they form a ring-like structure at the center. Multiple nucleus are forming, and the most important, the cytoplasm have vacuoles. Can you see the vacuoles in the cytoplasm? So these are the 3 main type of giant cells. Can you enumerate? And the last one is the giant cells which are present in tumor. They can have any structure. So can you tell me the types of the giant cells? Who will tell me the 4 types of the giant cells? The first one is the foreign body. The second is the Langerhans. The third is the Taunton. And the fourth one is the tumor. This is Langerhans. So can you help me in drawing the diagrams? This one I will tell you 2 patterns. This one or this one. Who will tell me? Where should I draw the nucleus? So in foreign body, nucleus is haphazard. Say it is haphazard anywhere. It is haphazard anywhere in the cytoplasm. This is foreign body. In Langerhans, either at the poles, north pole, south pole, either at the poles, or it is present at the periphery in the form of the two-third ring, like this. You got it? In the Taunton, it will form a ring at the center. And the cytoplasm contains multiple vacuoles. This is very important for Taunton. And in tumor, there is no fixed thing. It can be anywhere. So these are the 4 types of the giant cells you have to learn with their examples. So foreign body, it is scattered throughout the cytoplasm. Example is leprosy and TB, right? And in Langerhans, it is present either at the periphery or at the 2 poles. Example is TB and sarcoidosis. You have to learn the examples. And in Taunton, you can see this diagram. Beautiful diagram I have drawn for the foreign body. Beautiful diagram I have drawn for the Langerhans. Appreciate the difference. And in Taunton, it is present in the form of a ring, and example is xanthoma. So we are done with the various types of the giant cells. So that's all about chronic inflammation. You should know the examples. I will provide the PDF. You can learn the examples. So I am done with chronic inflammation also. Right. So few more important topics in the general pathology are still remaining and the time is less. So I'll be a little bit fast and select only those topics which are important. Right. In this session, we are having half an hour more. In this session, we will complete general pathology. Hematology and systemic I will cover in the evening. In the evening, I will start from 6 till 10 or 11. So 4 or 5 hour session, we are having a long session in the evening. Right. So in the evening, I will cover entire hemat. I will start with hemat and I will move to the systemic further. So let me complete the general here. You got my point? Can we go ahead? So the next important topic is the edema. What is edema? हिंदी में कहते हैं इसको सूजन आ गई, right? So it's very important complaint given by the patients to the doctor. Doctor, मुझे सूजन आ गई है यहाँ, anywhere on the body. It's edema. So what is the definition of the edema? Human body is made up of cells. All organs are made up of cells. Can you see a cells here? 1, 2, 3, 4, 5. I can see multiple cells. Come on, right? Multiple cells. And this is the blood vessel. Right? Inside the blood vessel, the blood is present, right? When fluid from the blood comes out and it accumulates in the space here, this space is known as interstitial space. What this space known as? When the fluid accumulates in the interstitial space, the organ swells and it results in edema. So what is the definition of edema? Edema is abnormal and excessive accumulation of fluid in the interstitial space. It looks like this. If you press it, it will pit. It is the edema, right? Yes. So edema is the accumulation of the fluid in the interstitial space. There is one more related term, effusion. What do you mean by effusion? Effusion may be accumulation of fluid, but not in interstitial space. It is in body cavities. In the human body, there are few cavities. Like we have pleural cavity. You know about pleural cavity? Around the lung, we have a pleural cavity. In the same way, around the heart, we have pericardial cavity. Right? If fluid accumulate in the cavity, it is known as effusion. But edema and effusion have same pathogenesis. Give me a thumbs up. So can you define edema for me? Can you define effusion for me? Can you define the two things? Edema is accumulation of fluid in the interstitial space, right? And effusion is accumulation of fluid in the body cavities, But accumulation of fluid is common in both of them. So pathogenesis is common in both of them. Say yes, got it? So I will tell you the pathogenesis. How does edema or effusion occurs, right? So you may get question either on edema or on effusion. To understand that, you must understand the normal Starling's law, the normal type of pressure, normal pressures acting in human body. So can you see this is the artery? From the artery, the arterioles are coming out, converting into capillaries, and then veins are formed. So artery, capillary, and vein. This is the thing. Can you see this is the organ? These are the cells of the organ. These are the cells of the organ. Now this is the capillary. This is a capillary. Here, can you see this one, this portion, the central portion, capillary, not artery, not vein. I'm drawing a capillary. But can you see the capillary have, this end of the capillary is known as arterial end, and this end of the capillary is known as venous end. Say yes. So in the same way here, it is the arterial end of the capillary, and this is the venous end of a capillary, but basically this is a capillary. This is not artery, not vein. You have to understand this is a capillary. This is a capillary. Now this is the organ. These are the cells of the organ. Now in the artery we have pure blood. In the vein we have impure blood. Pure means contain oxygen. Oxygen is present. Impure means oxygen is absent. You got my point? So have you ever thought how does pure blood convert into impure? While traveling through a capillary. This side we have artery. This side we have vein. It have pure. It have impure. दोनों को connect करती है capillary. Capillary is connecting the artery to the vein. So how does the pure blood convert it into impure while passing through a capillary? Why it happens? Have you ever thought it? Okay, let me tell you. So whenever the blood entering, the pure blood entering here from the arterial end into a capillary, it comes out. The fluid comes out. The fluid comes out. It contains oxygen. It will give oxygen to the cell. Take carbon dioxide from the cell, and at venous end, it again go in. So it is coming out, do the exchange. Give oxygen to the cell, take carbon dioxide and waste product from the cell, and again enter in the vein, and here the blood will become impure. It happens in all of us. Even at this moment, it is happening inside me, you, everyone. We don't think about it, but it is happening. In every organ, this thing is happening. Now see how God have created this human body beautifully, beyond imagination. We are, we are using our brains and everything in understanding the process, but it is constantly happening inside us. Right, we are not aware, but it is happening inside us. In each and every organ, at each and every cell inside me, this is taking place right now. Every one of us, right? So the fluid is coming out, does the exchange and goes in. So how does it happen? The fluid comes out, does the exchange and goes in. So there are two types of pressures. The hydrostatic pressure and oncotic pressure. Hydrostatic pressure is pressure due to water, it is outward pressure. And oncotic pressure is inward pressure. You got my point? So when the fluid is coming here, and it is going out throughout the thing, the oncotic pressure is same. Oncotic pressure is same throughout, and it is 25. It is 25 and throughout the thing it is same, right? But hydrostatic pressure, since here fluid comes out, so hydrostatic pressure will decrease. So initially the hydrostatic pressure is 38 and later on at the venous end it will become 12. If you don't want to learn the values, it's okay. Just understand the concept. I want to say at hydrostatic pressure, these are the pressures. At arterial end. And at venous end, these are the pressures I want to say. You have to see the pressures. Here outward is more, inward is less. So net, if you subtract the two, it will be 13. 38 minus 25, it will be 13, but net is outward. And at the same time, if you see the pressures at the venous end, here inward is more than outward. Again, if you do 25 minus 12, it's 13. But here 13 outward, here 13 inward. I mean to say with 13 mm, the fluid comes out. Does the exchange. With 13 mm fluid goes in. So there is no edema at the end. Inside me, I don't have edema anywhere in my body. Because at everywhere, these pressures are taking place inside me. At every arterial end, I am having 13 mm of pressure outward. And at every venous end, I am having 13 mm inward. So, jitne pressure se fluid bahar aa raha hai, utne se hi andar aa raha hai. At the end, my tissue is dry. I don't have accumulation of fluid here. You got my point? If you got my point, give me a thumbs up. If you got my point, give me. हिंदी में कहूँ तो जितने प्रेशर से फ्लूइड बाहर आ रहा है उतने ही प्रेशर से अंदर जा रहा है. तो आर्टेरियल एंड पे बाहर आता है, एक्सचेंज करता है, वीनस एंड पे अंदर चला जाता है. एट द एंड टिश्यू के पास कोई एक्स्ट्रा फ्लूइड नहीं है तो एडिमा नहीं है. द टिश्यू इज ड्राई. देयर इज नो एडिमा एट द एंड. But if some changes occurs in the pressure, either outward is more or inward is less, so there is accumulation of fluid. या तो outward ज़्यादा है या inward कम है, तो there is accumulation of fluid that leads to edema. Give me a thumbs up. That is the pathophysiology of edema. So edema can occur because of two reasons, either due to increased hydrostatic pressure or due to decreased oncotic pressure. Hydrostatic pressure is outward pressure, either due to increased outward pressure or due to decreased inward pressure, right? So these are the two reasons for the edema, right? And third thing, you will say, ma'am, it is very complicated. Is it really? Means first time when I read all this, I was wondered, oh my God, this is taking place inside my body. I'm not aware about it. And it is such a complex thing that reading so is very complicated. But this is happening inside me. I was wondered. I was surprised. I was, salute to God who has created such a complicated mechanism inside us. But what if, just suppose I'm having 13 mm here and 10 or 12 or 9 mm here, thoda bahut 1 mm ka fark hua, to I will have a little edema. That can happen, na, little edema. But God has given a backup also. Great God, that has given a backup. The backup is the lymphatic. Chota mota edema hoga to lymphatic leke chala jayega. Right? So at the end, we don't have any edema. But if someone have lymphatic obstruction, the person can have edema. So you got the three reasons for the edema. Either increase outward pressure, or decrease oncotic pressure, or lymphatic obstruction. The three. The fourth is the sodium water retention. And the fifth is the increased vascular permeability. That is holes in the wall of the blood vessels, so fluid will come out. I have told you in inflammation, the tumor of the inflammation. So these are the 5 causes of the edema on which you can get maximum MCQs. You must understand the 5 causes of the edema, right? Now let me tell you the 2 types of the edema. You can get the question on the 2 types. Edema is of 2 types. Transudate and exudate. What do you mean by transudate, exudate? Beautiful diagram. Listen. Let me draw a blood vessel to explain you the 2 types of the edema. This is the blood vessel. This is the lining of the blood vessel. That is endothelial lining, which is continuous. Right? This is continuous. This is the fluid present inside the blood vessel. Now imagine the situation if hydrostatic pressure is more or oncotic pressure is less. Right? In that situation, what will happen? You will say, ma'am, this fluid will come out because of the imbalance. Yes, I agree. But only fluid will come out, nothing else. Only fluid. Fluid can come out even if the cells are continuous with each other. The endothelial cells are continuous with each other without any gap. The fluid can penetrate. The fluid can penetrate and accumulate here. It will lead to edema. Such a edema which contains only fluid, nothing else, it is known as transudate. Let me draw a second diagram to explain you the exudate. So let me draw the second diagram in which gaps are present in the wall of the blood vessel. These are the gaps I am drawing. It is not continuous. The blood vessel wall is not continuous. See the first and see the second. The blood vessel wall is not continuous. There are gaps are present. That is, there is increased vascular permeability. I can see the gaps. The increased vascular permeability due to inflammation. So here what happens now? The fluid will obviously come out. Fluid to aayega hi aayega. Fluid will come out. But along with fluid, the protein and the cells will also come out because of the gap. Initially, there was no gap. So only fluid was coming. Here, along with fluid, the protein and the cells are also coming out. So such a edema which contain along with fluid, abundant of cells and abundant of protein is present. Such a edema is known as exudate edema. The 2 types of the edema. Give me a thumbs up. So same diagram from Robbins you can see in front of you. Right. So give me a thumbs up, everyone. Everyone give me a thumbs up. You got it? Right. So can you see the first diagram? See the continuity. Appreciate the continuity of the endothelium. Appreciate it. There is no gap. And appreciate the 2 arrows. Hydrostatic is equal to oncotic. The 2 arrows are equal and opposite. So no edema. It happens inside me, you all healthy humans. We don't have edema. We don't have gaps. But imagine if hydrostatic is more or oncotic is less. See the beauty of the diagram means I salute Robbins and Cotran and all the authors who have written the book. See, मतलब author को कुछ बोलने की जरूरत ही नहीं है. भाई diagram में उसने दिखा दिया this arrow is more thicker and this arrow is thinner. So don't read the text. At looking at the diagram, I can understand this pressure is more, this is less. So outward is more, inward is less. What will happen? But there is no gap. No gap. Still no gap. So only fluid is coming out. Only fluid. So such edema is transudate. Low protein, low cell, only fluid. Only fluid. See the third diagram. See the third diagram. I can see a gap here, a gap here, a gap. Appreciate the gap. Appreciate the gap. Now from the gap, fluid to aa fluid is coming, but along the fluid, I can see the protein and the cell. So such edema in which along with fluid, protein and cell is also present, it is known as exudate edema. Right, the two types of the edema. Now you will never forget. Now you will not forget. So transudate is protein poor, cell poor. Exudate is protein rich, cell rich. Have any doubt? I guess you don't have any doubt. Protein poor, cell poor edema, protein rich, cell rich edema. Right. Since low protein, so here protein is less, here protein is high. Right. Specific gravity is less, specific gravity is high. Because it is having low cells, it is having high cells. So specific gravity you can see. Right. LDH is low, LDH is high. Because LDH is corresponding to the cell. If you have more cell, more LDH. Less cell, less LDH. Few cells, more cell. That all we can understand. The only thing which is opposite here is the pH. pH is more in the transudate as compared to exudate. pH is more in the transudate as. So you can compare transudate and exudate. Who is having more protein? Who is having more cell? Who's having more specific gravity, who's having more LDH, and who's having more pH? Can you answer it? I guess here protein, cell, specific gravity, LDH, everything is more in exudate, but pH is more in transudate. That I mean to say in simple language. Everyone give me a thumbs up. Yes. Right. So can we go ahead? Can we go ahead? So that is about transudate, exudate. Now I'm not helping you in solving the MCQs. I can guarantee you solve any MCQ of edema, you will hit it. You will hit it. Because if I give you MCQs also, it will take time and we have limited time. Understand it. I cannot teach you theory as well as MCQ. I can do one thing. So I guess teaching theory is the best thing. You can solve any MCQ. Any MCQ. Whatever you open, you can do it. I can challenge. So edema is done from my side, I guess. Moving to the next topic. Moving to the next topic. Okay. I will teach you 3 CVC. CVC is very important. CVC is chronic venous congestion. Okay. Can you see? Yes. This is artery. This is vein. And connecting them is capillary. Yes. Hannah. So in an organ, the artery is coming. Let me draw an organ. In this organ, the artery is coming. The artery is converting into the capillary. And capillary leads to vein formation. I guess you all can see it very beautifully with the beautiful colors I have drawn. Now imagine two situations. The first situation, the artery got dilated. Vasodilatation of the artery. What will happen? You will say, ma'am, organ receive more blood. The organ will receive more blood, but this blood is pure blood. The organ is receiving more pure blood, right? So organ will look more redder. And this condition is known as hyperemia. It is more blood to the organ due to dilatation of the artery. So the organ is receiving more blood. Organ look red, more pure blood. Imagine the second situation. The vein got obstructed, not dilated, obstructed. The vein got obstructed. Impure blood cannot leave the organ. Impure blood will accumulate here only. Here also we have more blood in the organ. But this time the blood is impure. Here also more blood, here also more blood, here also more. But here the blood is impure. So organ look blue in color. It is cyanosis. So this condition is known as congestion. So my point is that hyperemia and congestion are one and the same thing. The definition of both of them, hyperemia and congestion, is same. More blood in the organ. Hyperemia, more blood in the organ. Congestion, more blood in the organ. But here we have pure blood, so organ looks red, erythema. And here we have impure blood, so organ looks blue, cyanotic. This one is due to arterial vasodilatation and this one is due to venous congestion. Give me a thumbs up. For dilating an artery, you require ATP. That's why this one is an active process. For obstructing a vein, you don't require ATP. That's why this one is passive. Give me a thumbs up. Everyone, kahan ho sab log? Give me a thumbs up. You got it? Right? So don't make it a unilateral lecture. No? Interact with me. So hyperemia, congestion, one and the same thing. I'm interested in congestion. You got it. I guess you all got it. What is hyperemia? What is congestion? This one is active. This one is passive. This is due to dilatation of artery. This is due to obstruction of vein. Here, oxygenated blood is there, so organ look red and erythematous. Here, deoxygenated blood is there, so organ look blue and cyanotic. Right? So I am interested in congestion. Congestion may chronic venous congestion. I am going to teach you 3 types of chronic venous congestion. CVC, the full form of CVC. Students even don't know the full form of CVC. It's chronic venous congestion, also known as CPC, chronic passive congestion. As I've told you, congestion is passive, no? It's not active. So CVC and CPC is one and the same thing, right? Now I am going to teach you 2 things. Can you see a diagram of heart? You all know the cycle. I'm not explaining you the cycle. Now imagine two scenarios one by one. Imagine the left heart is failed. The left ventricle is not pumping. Oh my God, what will happen? Normally, when the left ventricle pumps, the blood goes in aorta and distributed throughout the body. But now it's not pumping. What will happen? Where the blood will go? Blood cannot go ahead. Blood will go backward. From the left ventricle, it will go to left auricle. From left auricle, it will go to pulmonary vein. From pulmonary vein, it will go and accumulate in the lung. So more blood in the lung. More blood in the lung because it is coming from the vein, pulmonary vein, venous obstruction. So it is known as CVC lung. It is known as CVC lung. Yeah, pulmonary edema, it will lead to CVC lung. One and the same thing. Yes, absolutely right. So my point is that left heart failure leads to CVC lung. Say yes, say yes. Imagine another situation. Right ventricle is failure. Right ventricle is not pumping. What will happen? The right ventricle is not pumping, so blood is not going ahead. Normally, when the right ventricle pumps, the blood goes for purification to the heart, to the lungs. But now right ventricle is not pumping, so blood goes backward from right ventricle to right auricle. From right auricle to superior inferior vena cava. And from superior inferior vena cava, it will go and accumulate in all organs of the body. All organs, literally all organs. But I cannot teach you all organs here. No, I will select the two important one. I will select the important liver and spleen. So basically, right heart failure leads to CVC liver and CVC spleen. Basically, CVC of all organs. But left heart failure leads to CVC lung. You got this point? You got this point? Left heart failure leads to only CVC lung. Only CVC lung. But right heart failure leads to CVC of all organ. Important among them are liver and spleen. So we are having now three organs to be read, right? You can see here, left heart failure, only lung CVC. But right heart failure, multiple organ CVC, out of which these two are important. Right. So please learn. I'm giving you only punchline. I'm not explaining you the complete diagram here. CVC lung, it occurs in left heart failure. CVC liver and CVC spleen, it occurs in right heart failure. So this is the most important MCQ you must know. It is the basics. It is the basics you must know. Left heart failure and right heart failure. Now in microscopy, they have one word to be picked up. One word which is very important. I will explain you also. In CVC lung, there are heart failure cells. Heart failure cells, because it is occurring in left heart failure. Heart failure cells are present. What are they? I will show you. In CVC liver, there is nutmeg liver. Nutmeg. I will show you what do you mean by nutmeg liver. And in CVC spleen, there is gamma Gandy bodies. Gamma, तीनों पे MCQ है. Gamma Gandy bodies. On all these three important catchy words, you have your PYQs on all. So heart failure cells are seen in CVC lung, nutmeg liver seen in CVC liver, and gamma Gandy bodies are seen in CVC spleen. I will show you all three diagrams also to understand it better. Say yes. Shall I move to the diagrams? I must. So CVC lung, you can see this is the CVC lung. So whenever there is more blood in the veins, so can you see these are the veins? These are the capillaries. They will rupture. Blood will come out. The blood, can you see the blood is coming out? They are rupturing, the blood is coming out. The RBCs are coming out. These RBCs which are coming out are engulfed. Mind my words. They are engulfed by a macrophage. Those macrophages are known as heart failure cells. So what is heart failure cell? The capillary is rupturing. From the rupture of the capillary, the RBC are coming out. RBC is coming out. From the RBC, hemoglobin is coming out. Hemoglobin get converted into hemosiderin, and that hemosiderin is picked, engulfed by a macrophage. So a macrophage containing hemosiderin is known as heart failure cell. Give me a thumbs up, say yes. So what is a heart failure cell? It's a macrophage containing hemosiderin. So hemosiderin kahan se aaya? Hemosiderin is coming from the hemoglobin. Hemoglobin kahan se aaya? It is coming from the RBC. RBC kahan se aaya? Rupture of capillary. Right? So in this way, you have to understand these are the heart failure cells. Heart failure cells are present in lung, not in heart. It is a misnomer. By looking at the word, you may feel heart failure cells present in heart. No, they are present in lung. They are present in lung in case of when the left heart failure is there. Right? And these are hemosiderin containing macrophages. Hemosiderin-laden macrophages. Very important PYQ, repeated multiple times in your exam. You can't afford missing it. So that is CVC lung. CVC liver is nutmeg. Nutmeg का मतलब क्या होता है in Hindi? You know Hindi? Any one of you? It is something which is present in our kitchen. We eat it. It is a eatable. It is a eatable. What is it? No. It is not sputum. Nutmeg. The meaning of the nutmeg. Something present in our kitchen. You love nutmeg, William, but what it is? Can you tell me what it is in Hindi? What do you call it? Not supari meat. Not pan. Is Isaac. Not biryani. It's not biryani. Yes? You people are too funny. Yes, Jaifal. Yes, Jaifal. Who is it? Nitesh and Meera. Very good. It's Jaifal. Have you seen Jaifal? This is Jaifal. I use it in milk powder. The milk becomes delicious after adding it. Just in winters, boil the milk, add a little bit of Jaifal, add a little bit of kesher, add a little bit sugar. It becomes delicious. So it is usually used in Indian kitchens. It's Jaifal. Right. Now, why the liver is known as Jaifal? Why it is nutmeg liver? What is the similarity? Now, can you see the Jaifal? I mean, can you see the nutmeg? It's red, yellow, red, yellow, red, yellow, alternate red, yellow. In the same way, the liver is also there, alternate red, yellow, red, yellow, red, yellow. That's why this is the simile. That's why it is known as nutmeg liver. Nutmeg liver, alternate red and yellow. Say yes, alternate red and yellow. So nutmeg liver is seen in CVC liver. CVC liver is the nutmeg liver. Now, why in the nutmeg, can you see, you already know the lobular model of the liver, I guess. You can see in the center, we have a vein, the central vein. At the periphery, we have a portal triad. It is a hexagon. We have a portal triad. And these are the hepatocytes. You can see the yellow color hepatocytes connecting the two, right? Now, in the liver, what we are having, this vein ruptures. The central vein is rupturing because of the more blood in that, congestion in that, because of the right heart failure, because of the backward flow, more blood is going in the central vein. So this vein will rupture. So what will happen? All the blood will come out and the blood will accumulate here. The blood will accumulate here. So center is red. The center is red. But at the periphery, these hepatocytes will show fatty change. So the periphery is yellow. So it's looking like alternate red and yellow. That is known as nutmeg. Let me draw a few hexagons or lobular model to explain you the nutmeg. This is the liver. You all know na, liver is hexagonal lobular model. I guess that sabko pata hai. The liver is like this. The liver have a hexagonal lobular model. I am drawing a normal liver. This is a normal liver. At the center of the normal liver, we have central vein. This is all central vein. And at the periphery, we have this thing, portal triads. Everywhere at the periphery, I'm not drawing it. So what is happening? The central vein is rupturing. So center of all is red. Because of the rupture, the blood comes out. So it leads to hemorrhagic necrosis. So center of all is red. And the periphery is due to the fatty change, it's yellow. Now, is it looking like nutmeg? Is it looking like Jaifal? So alternate red, yellow, red, yellow, red, yellow. Say yes. That's why it is known as nutmeg liver. Are you people there? So it's nutmeg liver. So nutmeg liver is like this. The diagram is like this. You can appreciate this is the central vein. It is rupturing. So you can see the blood is coming out, the hemorrhagic red color. And you can see the peripheral, these hepatocytes are showing this fatty change, the yellow, yellow fatty change. So alternate red, yellow is like this, right? Coming on the last, CVC spleen. CVC spleen. In the CVC spleen, you can learn it's gamma Gandhi bodies which are formed. These are the gamma Gandhi bodies. It is due to the, there are two types of pulp in the spleen, the white pulp and the red pulp. So your red pulp is increasing and causing the rupture. And because of the rupture, the hemoglobin is coming and depositing on the fibrosis. And it is leading to gamma Gandhi bodies. So what we have understood, what we have learned, CVC lung have heart failure cells. CVC liver have nutmeg liver and CVC spleen have gamma Gandhi bodies. 3 PYQs. Ultimately, you have to learn that. However you learn, you have to learn that. Say yes. Yes. So we have learned the 3 type of this thing. Now you will help me in answering this question. Can you help me? The easiest question I must say. It is very easy. It's very easy. Dr. Shubh, you don't know that liver is hexagonal? Okay. It's the hexagonal model of the liver. In a hexagon, we have multiple hexagons on the liver. The best model is the lobular hexagonal model. Okay, so what is the correct answer? Gamma Gandhi bodies are typically seen in CVC of what? Of course, the gamma Gandhi bodies are seen in CVC of spleen. You all are right. Very good. Can you tell me the next question? Heart failure cells are seen in CVC of what? Is it CVC lung, kidney, spleen or liver? The same 4 options. But only question me, one thing is changed. So I'm asking heart failure cells. So you all are right. Very good. Who is first to answer? Abhi, Andrew. You are first to answer. Very good. So of course, it's seen in CVC of lung. That is left heart failure. So correct answer here is A and you all are right. The next question, very easy, nutmeg liver. I'm sorry, I said the answer, it's liver. Nutmeg appearance is seen in which organ? In CVC of which organ? So nutmeg is liver, right? So that's Jaifal, alternate red, yellow. Now you will not forget. So correct answer here is D, right? Can you tell me what are heart failure cells? The definition of heart failure cells. What are they? Is it lipofuscin granules in the heart cell? Is it pigmented alveolar macrophages? Is it pigmented pancreatic cells? Or is it pigmented cells in the liver? What are heart failure cells? I told you. So in the lung, the capillary rupture, the RBC come out, the RBC rupture. the hemoglobin come out. Hemoglobin convert into hemosiderin. Those hemosiderin is engulfed by a macrophage. So it's alveolar macrophage, the lung macrophage, which have taken the pigment. Name the pigment. The pigment is hemosiderin. So basically these are hemosiderin laden macrophages of the lung. So correct answer here is B, and I guess everyone can confident now, right? So correct answer here is B. We are done with that also. Say yes. Say yes. Right. So the next topic, the last topic I'm taking here is the thrombosis. Remaining session, what is remaining now, I will take in the evening only. So what is thrombosis? A clot formation in the blood without any injury. If a clot is formed in the blood vessel, can you see a clot here? Can you see a clot here? So that is known as thrombosis. We all know. The most important MCQ here, why a thrombus formed? The reason for the thrombus formation is the Virchow triad. Virchow triad. You must learn the triad, the three things in the Virchow triad: endothelial injury, stasis, and hypercoagulability. Now, I'm not going in the details to explain you why, how does it form. It will take time, but only thing you have to learn the triad. I don't understand the details right now. It's not time to understand the details. So coming on the types of the thrombi, there are two types of thrombi. If the thrombus is formed in the artery, it's known as arterial thrombus. If it is formed in the vein, it's known as venous thrombus. Now, can you see a beautiful diagram I have drawn to explain you the difference between the arterial and the venous thrombus? Okay. Can you see an organ? Say yes. This is the artery. See the flow of the blood. It is coming towards the organ. This is a vein. See the flow of the blood. See the arrow. I have drawn it intentionally. It is taking the blood away from the organ. Now see, I have drawn a thrombus here also in the artery. And I have drawn a thrombus here also in the vein. But the color of the thrombus I have intentionally drawn different. In the artery, the thrombus is pale or white in color because it is having more platelet. That's why it looks yellow, pale, white. Right? But in the vein, it is having more RBC. That's why the thrombus in the vein is red in color. So now you will not forget. The arterial thrombus is white thrombus and the venous thrombus is red thrombus. The arterial one have more platelet, more fibrin, more platelet. That's why yellow and white. But the venous one have more RBC. That's why red. Give me a thumbs up on every point. Say yes. Say yes. Right. The arterial one is incomplete. Can you see I have drawn till here only. So still blood can flow. Thoda sa upar khali hai. It is not complete occlusion. Incomplete is mural. But see the venous one I have drawn, it's completely occluding the lumen. This one is complete. Say yes, this one is incomplete, this one is complete. Right. The arterial one, can you see I have drawn the alternate lines. Alternate red, yellow lines like nutmeg only. So these are known as lines of Zahan. So lines of Zahan are present in arterial, but there are no lines of Zahan in venous. You have to learn the lines of Zahan. Right. Say yes, say yes. The next point. The most important point, the arterial thrombus, it grows in size in opposite direction to that of blood flow. Blood flowing in this direction, but the thrombus is growing in that direction. This is known as retrograde propagation. What does it known as? Retrograde matlab ulta. Retrograde propagation. But in venous thrombus, it is growing in the same direction as that of blood flow. It is known as antigrade propagation. Antigrade propagation. Say yes. Say yes. So retrograde, antigrade. The next point, imagine due to thrombus, less blood is coming to this organ. So this organ will have ischemia. Less blood is coming now. Due to the thrombus in the artery, less blood is coming. Pure blood is not coming in the organ. Organ will have ischemia. But in venous thrombus, pure blood is coming. There is no problem in coming. But there is problem in leaving the blood. So impure blood cannot leave and accumulate in the organ. It will lead to edema. So let me summarize the differences between arterial and venous thrombus. These are the differences. We have understood them clearly in the diagram. Now, no need to understand. No needs to understand. No, Dr. Anand. Lines of Zahan are present in arterial and absent in vein most commonly. Rarely, in rare cases, venous can also have lines of Zahan. But in MCQ, if it is coming that lines of Zahan are present in arterial or venous, you have to go with arterial. If the option both is given, you can go with both also. Rarely venous can have, but not always. So that is my explanation to you, Dr. Anand Thakur. You got it? Yes, but in MCQ, if you are not getting both the option, go with arterial. It is more common, always more common in arterial, always associated with arterial, right? Lines of Zahan are alternate red, yellow lines. The red line is due to RBC and the yellow line is due to platelet and fibrin. So these are visible in arterial, but not in venous. That is my point, right? So you have to learn the differences. So we have seen the differences, arterial and venous. Arterial grows in retrograde manner. This grows in antigrade manner. Arterial mein lines of Zahan present. Venous mein lines of Zahan absent. From Hirschman only I have picked this table, Dr. Anand Thakur. You can check the latest edition of the Hirschman and see this point in the table. It is still mentioned in this edition also, right? So occlusion here is incomplete and here it is complete. Here complication of ischemia, here complication of edema. Here, this one is looking white or pale. This one is looking red because of more RBC. Everyone give me a thumbs up. Everyone. I would like to stop here for right now and I will continue the lecture in the evening. So only few more important topics from the general are left, but I will continue those in the evening, including hemat and systemic. So thank you so much. And I would like to start my session in the evening at 6 p.m. sharp. 6 p.m. sharp here only on this YouTube channel only. So thank you very much for being with me, giving your precious time to me. I'm ending the session here right now and thank you so much. Stay connected, bye, and I want all of you to come back in the evening today 6 p.m. sharp on this YouTube channel only. You will find me live at 6. So session will be from 6 to 10 or 6 to 11 you can say. We will cover the most important topics. Bye-bye. Study hard. Wishing you all the best for your exams.